This to, please? I don't.
Yes, Dr. Himanshu Mehta is sending it to me.
Put it on the chat
Who am I
box.
sending it to, Kumar?
Himanshu, put it on the chat. Himanshu, put it in the chat.
Amar?
Can we start?
Yeah.
Okay. First of all, welcome everyone.
Okay, I can't get my video to come on.
Stephenson, just send it to Himanshu. Himanshu, put it on the
Okay,
chat.
it has to be. It's too big to send over email. I have to send it on a Hightail.
Okay, ma'am, we're just starting the session now.
We're just starting.
I'll talk. Can you just text me your address?
Can you
Telephone
mute yourself?
We're starting the main session now. Yes, go ahead, Amar.
So, hello everyone. First of all, welcome for this annual conference of the IIRSI. I'd like to introduce, first of all, the chairman of the scientific committee, Dr. and Professor Mahipal Singh Sachdev. And Mahipal Singh Sachdev has got about more than 60, 70 centers all over the country in his Center for Sight. He's also the president of the All India Ophthalmic Society. Mahipal, few words.
Thank you very much, Amar, and welcome everyone, colleagues from overseas and India. And I wish to thank all the panelists and the speakers who are joining in. I think the annual conference of IIRSI is a mega event, and this year, because of the COVID problems, we were not able to hold it in the physical form. So as we would say that because of the problem, the necessity was to have a digital conference, and we are having this digital conference. And I congratulate Amar and Ashwin for putting up this show. And we look forward to the presentations from all of you. And believe me, there are close to about 8,000 registrations already there from 36 countries. So this is a much better way to reach out to people who would otherwise not have come physically to Chennai to attend this conference. So I think without much ado, we will go on to the session. And I have the pleasure of inviting Dr. Himanshu Mehta. Dr. Himanshu Mehta would be taking over as the president of the Intraocular Implant and Refractive Society right from now. And as we all know that he's from Mumbai, he has done his MBBS and post-graduation from KEM, and then he went to Houston to do his retina fellowship. But just now he has the one of the largest practices in Mumbai for cataract and refractive surgery, and the who's who of Indian Bollywood comes to him, and I think he gives spectacular results. So congratulations, Dr. Himanshu, for taking over as president of the IIRSI, and I welcome you to co-chair this session with me.
Before you just start, 1 second, Mahipal, just I wanted to just say the numbers have improved right now. We are right now at 9,500 delegates, and we are touching more than 130 countries, ladies and gentlemen. So for IIRSI, that's a record number of delegates and from the number of countries. Saying that, I'd like to say also about Himanshu being the president of the IIRSI. It's such a pleasure to have you with us. Now over to both of you, Mahipal and Himanshu, to take over this symposia.
Thank you, Amar. Thank you very much. And thank you, Dr. Mahipal, for a lovely introduction. And I thank IIRSI for allowing me to be here this evening. And friends, welcome to this show, and all the panelists here. Thank you for being here. As you can see that IIRSI is one of the largest growing societies in the world. It has managed to do a lot under the leadership of Amar, Mahipal, and the doyens of Indian ophthalmology. As you can see, it has progressed from where it was to where it is, and the cataract refractive is regularly look forward a grand annual meeting which is there in July. But because of the COVID situation, we are here. Once again, as the president of the IIRSI, let me welcome all the delegates who are participating from almost 130 countries. Thank you for being with us this evening, and welcome to the show. You're going to have a great time for the next 2 days and all over the sessions conducting. I'll start with my presentation. It's a very simple one that it's eagle vision that I'm talking about. And as I always put it, that the eagle vision, a surgical experience is never just, or you go to a restaurant or you go somewhere, it's never just the food, it's the whole experience, which is very important. How you progress, how you move, who behaves with you, what is in your mind, how you are served, gives you the result. So my talk today is where eagles dare, and eagle vision following cataract refractive surgery. 6 cardinal steps to success. Analyze your patient, preoperative counseling. Most important part, I think, of 70% of the job done is in the first 2 steps. Analyzing your patient's expectations, because the expectations have grown too big. From the time of lying down in the hospital to a big tape on the eye with sutures to now, you want to tell your patient it's an ambulatory care, you don't have to worry, no prick, no stitch, no nothing, no hospitalization. So it undervalues the whole process, which we have mastered so well, the equipments and the surgical technique. So counseling is so very important to reduce their non-specific expectations of age-related other problems. Now, of course, from our side, the diagnostic diligence is so very important. Accurate biometry for the IOL power, understanding my own IOL technology. I'm doing a trifocal, bifocal, multifocal, EDOF lens, or the extended depth of focus otherwise. Assistance from the cutting edge technology, femtolasers, flax, Varion, our toric lenses to be put the right way, all the formulae which have been devised so well, Dr. Douglas Koch, you have Dr. Warren Hill, and of course from Australia we have our friend. So we have to be so thorough with whatever that's available on online. And of course, end of the day, everybody is 8,500 people listening to this, means we all are very self-demanding with surgical endpoints. The most important thing.
So free, and I can see everything so clearly. All the colors are looking so beautiful to me. Since last more than 2 years, I had never enjoyed such a.
Now, this is what every surgeon wants to hear. Eagle vision is not just seeing 6.5 or 6.4. It is how happy the patient is when they start recognizing things and they start things that they want to see. They were missing out everything in life. So despite having a high refractive error, wearing glasses for 50, 60 years of their life, their expectations have become very huge. They all expect that they will get spectacle-free vision post-cataract surgery, despite their vitreous, their retina, or whatever it may be. There's high refractive error, the cornea, the vitreous opacities, but they want 20/20 vision for distance, intermediate, and near at every given point of time. So spectacle-free vision post-cataract is now a mandatory requirement for every patient, which has helped us grow as surgeons, which has helped technology grow so well from the diagnostic dilemmas to the post-op or the surgical point of view and all the equipments. And look at this.
Thank you. Superb. The feeling is so different. I mean, I could see presentations on the screens. I could recognize people on airports. It's a wonderful feeling. It's a great experience. It's just if I use, it's a life-changing experience.
Now, this is what we want to hear. It's a life-changing experience. It doesn't matter what they read on the charts. We want to see that the patient, end of the day, should be a happy patient. Here, it's, as I said, it's all experience from the time he walks into my operating room. Before that, in my OPD, the staff mentality, how they deal with them, how they talk to them, how they intermingle, what kind of presentation, how are they looked after, what do they expect from us. And of course, you have an array of equipments available for diagnostic purposes, preoperative, your Varion, your IOL master, and everything that we have to have. And with the femtolaser, the latest Phaco machines, the small incisions that we have had, the toric lenses, how much we have advanced in the past few years. Technology and the IOLs have really kept us far, far ahead in life to see that we try and give the best possible eagle vision to patients. So keys for success are basically looking after patients the right way and looking at that patient selection, biometry, and accurate biometry, power calculation, surgical technique, and introducing premium IOL in your practice. Counseling your patients, and I guess this is what I wanted to tell the rest of the crowd. that it's not just what we do, but how we present to the whole patient, how we reduce their expectations, tell them exactly what we are going to do, because we are extremely diligent about what we are doing at every given point of time. Thank you, Maipal, for giving me the little time to say what exactly is Eagle Vision. It's a mutual experience between the surgeon and the patient and the doctor.
Thank you very much, Himanshu, for being the opening batsman. We'll go on to the next, and that is on a different topic again, which is not cataract, but we are looking at smile. So we have Mastering Smile by Dr. John Doen from US. So John, over to you, Mastering Smile.
Well, thank you very much for the introduction. Certainly want to thank Dr. Amar and Dr. Ashwin for the invitation. Certainly a pleasure to be with you all today. So I want to cover Mastering Smile and some things I've learned over the last 10 years. These are my disclosures. I'm a consultant for Carl Zeiss Meditech. So smile background, I first learned about smile in 2010 and had really total disbelief that you could take a femtosecond laser and do what we are so comfortable with excimer lasers. We started the trials in 2012 for sphere and then sphere cylindrical. And commercial usage began in March 2017. We didn't have astigmatism, but it immediately became about 35% of my practice. Once we got sphere cylindrical usage, we're essentially 95% of my commercial practice at this point. I still perform LASIK, PRK, and ICLs, but smile has just become so comfortable for us to do, and we think it does have some inherent advantages. Again, nothing against LASIK, PRK, or ICL. We've just migrated towards smile. And I had LASIK 24 years ago, loved my results, and had excellent outcome. So why smile? Well, I think that I tell patients that there's no smell, no sound, no pain. There's no flap. I think there's better biomechanical strength. And I think the peer-reviewed articles have certainly shown that there's less dry eye. One thing that has been interesting, and probably one of the biggest reasons I continue on with smile, is there's a lower enhancement rate. We have found that our smile enhancement rate is 1/3 that of LASIK. And the same finding occurred without really any collaboration from Dan Reinstein, Detlef Breyer, Schroegenash, and Dean Corbett of New Zealand. We've all found that our enhancement rate is about 1/3 with smile compared to LASIK. Why is this? I think it's we're treating the patients essentially in a vacuum. The cornea acts as a vacuum. We don't have to worry about the environmental issues with humidity, particulate matter, and temperature, and drying of the stroma we see with excimer laser. So again, the one aspect of smile that I think is so important, this is really how to master smile, so critical that I think the number one point in teaching smile is the surgeon has to find the anterior interface and the posterior interface. Once these are found, much like doing cataract surgery, if you do a perfect continuous curvature or capsulorhexis, the rest of the case goes very well. And that is really the number one key in teaching smile and doing smile, that you have the posterior and anterior interfaces identified, and then you can proceed with the surgery. Again, how to master. I think it's very important for anybody that wants to learn smile. It is a new technique. This is going to require new manual dexterity. Even though you're an accomplished anterior segment surgeon or a laser vision correction surgeon, there's new things with your hands, with your fingers, that you're going to have to master since you're doing surgery inside of a pocket. This will take some time. I think it's very important to watch training videos, as many as you physically can, to learn the pointers and the things that others have gone through, so you don't have to rediscover or relearn things that are easily teachable. And it's very important, I think, to find a proctor that can help you with your initial cases. I would certainly recommend that the first patients you treat would be 4 to 10 diopters of correction. This makes life much easier because you're dealing with a larger lenticule. If you start with the lower cases, the 1 to 3 diopters, it's a very thin lenticule, and it's just going to make your life harder. So treating the higher levels of myopia will make your life easier in your first cases. And then again, the key issue is identifying the anterior and posterior lenticule. Real quickly, is there a nomogram? As I mentioned, IOL rate, and real quickly, everybody has found the same enhancement rate with smile compared to LASIK. That's it for me. Thank you very much for your attention, and enjoy smile.
Thank you very much for your nice presentation. Can we just have 1 or 2 points on discussion? Shiraz, what is your thought process about the take-up of Smile in Europe or in US and in Asian countries? Any idea as to whether people are lapping up and whether the other companies are also working on getting onto something equivalent to Smile, switching over from LASIK?
Well, I think that one of the problems we've had overall is the refractive surgical market in Europe, in particular, certainly in the UK, has the bottom's fallen out of the market. The numbers of procedures have gone down dramatically. So making a financial case for doing Smile is just not valid. The take-up of Smile is moderate to low, in my observation. So we don't have that level of excitement. So the numbers overall in the UK are low, and as a result of that, the numbers of Smile are also low. I have seen an uptick now. Patients are increasingly coming in for laser refractive surgery, and it seems a bit odd that maybe it's this COVID phenomenon and a glass is fogging up, and they're worried about contact lens infections and so on. So we have seen an increase, but nowhere near the levels we had maybe about 6, 7, 8 years ago. So do I do Smile? No. Do I plan to do Smile? Not for the near future, perhaps in the very long term. And the answer to your question about other players, I know that Bausch & Lomb and the medical monitor have developed a Smile alternative on the Victus, but I don't think it's going to go very far because of the level of enthusiasm for it. And I know that Schwind have developed something similar, and other femtosecond laser players are working on it, but I don't think they're working with the same level of enthusiasm as they perhaps did a few years ago.
Ron or George, you want to say something? Any comments on the first two presentations?
Yeah, I think they were really good. A quick comment about Smile. I think there is some trend for people wanting to pursue it in the United States. And I know that there are a few other companies that are beginning to kind of look at designing their own femtosecond laser. And as we see that mature a little bit more, and there's more representation from different commercial entities, I think the market for Smile will likely grow. It's just taking a little longer, maybe in UK and the US, just because of our FDA. But I can see some traction building. And John Doan's been one of the real leaders here in the US. So good presentation.
Okay.
I have a quick comment too.
Yeah. Sure. Yeah.
Yeah. So I think one of the I think I kind of share the points that Shiraz Daya just highlighted there. I think one of the main points about Smile is that the fight against excimer laser is a very difficult fight, and to have a room for Smile is you have to find exactly what are the patients who will really benefit from it. So I think one point to highlight is we know from the biomechanical standpoint that Smile is somewhere between PRK and LASIK, right? So I think one good point in favor of Smile is that any patient who would have a high PTA, for instance, for LASIK, maybe that patient would benefit from Smile. It's a place where they can probably find a room to have a higher number of patients. Second, I know it's very impressive, this rate of retreatment enhancement being 1/3 of LASIK cases. But when you have a complication, for instance, epithelial ingrowth, to me it's still very difficult to handle with Smile. So this is one of the points that need to improve, and I would love to hear from John Doan how he handles that. But I mean, I do have plans to do Smile. I think there's a room for Smile in the refractive surgery world, but there are some issues to be solved.
Marconi, I'd say on the epithelial ingrowth, I found it to be very infrequent. The interesting thing is, all you have to do is essentially irrigate. You can do this at the slit lamp, or you can certainly do it in the laser suite. But if I were to see it, it's always going to be at the incision. It tends to, if there's going to be epithelial growth, it's not like LASIK epithelial growth where it may take weeks or months to become evident. With epithelial growth with Smile, within like 48 hours, because they become very symptomatic. And you look at their topography, it's almost like a micropellucid marginal degeneration. It creates an irregular astigmatism, lost lines of vision. So the patient will tell you very quickly, you can take them to the slit lamp with a typical LASIK cannula and literally just irrigate the epithelium out, and that usually solves the problem. So it's not been a huge issue or cumbersome issue for me as a surgeon.
So I think finally, I'll just wish to say is that at least in India and in China and in Asia, East Asia, only the centers which are doing smile are actually showing the most rapid growth. And apart from the biomechanical stability that we are talking about, the other thing that is important is that the incidence of dry eye is much lower. The stability of the correction and retreatment rates are very good. And as also what is very, very important is that the environmental factors of temperature and humidity, etc., have no effect on the outcomes of smile. The only thing which these people need to add on is the cyclotorsion compensation for astigmatism. But apart from that, the outcomes as also the higher order abrasions are much better in cases of smile. I am personally, we have about 6 smile units, and I think at least my personal practice, I'm doing, except for hyperopia or PRKs, all the cases of smile, and the outcomes are really good. And I think there are, all the companies are moving towards this, whether it's Schwind, whether it is Zymer, whether it's J&J, or even early phases of Alcon. So I think all the companies are working towards it, and Schwind I think has already got the CE mark. So I think without much ado, let's go on to the next presentation. Is there a shift in this thing, or should
I think Dr. D is not ready, Maipal, so we can ask Dr. Damien Goldberg. Dr. Damien, are you ready?
Yes.
Okay, so we have our next speaker, Dr. Damien Goldberg, speaking to us on Presbyopia eye drops. Thank you, Dr. Goldberg, for sparing your valuable time this morning. Dr. Goldberg is currently a board-certified ophthalmologist in Torrance, California, and a managing partner at Woolston and Goldberg Eye Associate. He's a well-known leader in the laser vision corrections technology and the refractive cataract surgery. To his award, he has new techniques in corneal surgery and micro-invasive cataract surgery. Welcome, sir. Looking forward to a lovely presentation on presbyopia eye drops.
Thank you, Dr. Madden. Thank you, Dr. Agarwal and Ashwin for having me. So I'm going to talk now on novel pharmacologic solutions for the treatment of presbyopia. I assume you can see my slides. Great. All right. These are my disclosures. Presbyopia is a natural age-related.
We still just see your screen.
We're not able to see your slides.
We don't see your slides, we see you.
Okay, thank you. Let's see. How about now? Okay, great.
Yes.
Thank you.
Yes, you're on. We can see
presbyopia is a natural age-related condition. It literally means old eye, diminished ability to focus on near objects. Gradual decrease in lens accommodation, which leads to a significant lack of functional near vision. The prevalence of presbyopia is high. In America, we believe it's greater than 100 million Americans. In the world, greater than 2 billion humans. Significant unmet need is there. Reading glasses are inconvenient and have a negative psychosocial implication, and there is currently no approved pharmacologic treatment. Surgical procedures exist, but are invasive and difficult to reverse. Mechanism of action of these new medications will be miotics that will exert a pinhole, increase depth of field effect without affecting accommodation. For these drops to work right, they have to be comfortable in installation, long-acting, excellent safety profile, no degradation of distance vision, and pupil modulation needs to correct the efficient size of depth of field without loss of night vision. So taking advantage of the pinhole phenomena, if you imagine a camera on the left, if you took a shutter of a camera and made it very small, you would be able to extend the depth of field for near objects, making them more clear. So the idea is to use the same principle on the eye. If you can make the pupil more constricted, near images become darker and more clear. One product that will be available later this year, intended for presbyopia, is called iFocus by OSRX. It'll be available in November. Trial of this product that was done looked at patients between the age of 40 and 60 who have presbyopia, and they were followed for 30 days. 40 subjects at 6 to 8 US sites. Primary endpoint was to look at 3 lines of improvement of best corrected near distance visual acuity. Second endpoint was to look at 2 lines improvement of best corrected near distance visual acuity. Subjects were measured for distance vision while driving, reading a newspaper, and reading a prescription bottle label were also recorded. Interim data so far of 22 patients demonstrates majority of patients through the 8-hour day maintain at least 2 lines of improvement using this drop twice a day. At hour 3, 73% had 2 lines of improvement. At hour 5, 68% had 2 lines of improvement. Through the day, 36 to 41% had 3 lines of improvement, respectively at hour 3 and hour 5. Majority of patients had no loss of compromise of distance vision in either eye for all time points. Majority of patients noted an improvement in reading the newspaper and prescription bottle labels, and adverse effects were mild and non-significant, including temporary burning, stinging, or blurry vision on administration of drops and a rare brow ache. Here's a graphical interpretation of the data. Again, looking at hour 3 and hour 5, you can see over 80% of patients got 1 line, 73 to 64% got 2 lines, 36 to 41% got 3 lines. Understanding the subjective data, at no point did anyone find driving vision was compromised using these drops at all. And then comparing the baseline when the patients did not use the drops versus day 1, day 7, day 30 when they used the drops, you see newspaper reading and prescription label reading improved with the use of the medication. So in conclusion, there will be several new pharmacologic solutions like iFocus available for our patients for the treatment of presbyopia. The potential benefits of iFocus compound medication warrants further investigation. Many of these solutions will improve quality of life by increasing near vision by 2 to 3 lines of improvement. All these solutions demonstrate a high safety profile and no negative impact on distance vision. Thank you very much.
Thank you. Thank you very much, Dr. Damien, for a wonderful presentation. How many patients really were thrilled and excited about the whole process when you were on this experiment?
Yes, they're all very excited to use it, everybody that we have. So we're excited to be able to show the full data when we complete the study.
Dr. Waring, you have any comments?
Well, hold on 1 second. I can't see the screen. Oh, there you are. My first comment is that I'm really excited about
Do you
drops.
have any comments on the presentation? On the presentation on presbyopia eye drops?
I'm just joking because he's presbyopic now.
Yeah, right.
Yeah, I know. That I understand, but
it may have been too early here in the United States for me to try to make that joke. No, I'm really excited about this technology. I think that we've got four or five drops in the pipeline currently in the United States, and we really see this sort of as a bridge in the overall treatment of presbyopia. So this is what we're thinking kind of for the first stages of lens dysfunction. This is sort of perfect. We anticipate that this will be very popular, and not only with MDs, but also with optometrists in the United States. This will also be a very interesting option for prescription, being able to help patients. But hopefully this also bridges people into a surgical solution as well, as their presbyopia becomes more manifest and they're looking for to not need to deal with the hassle of eye drops, a lot like glaucoma treatments and minimally invasive glaucoma surgical treatments as well. So it may be a natural bridge to increase what's already very, very popular for the surgical treatment of presbyopia. So we look forward to having availability through the FDA approvals to these drops here soon.
Presbyopia treatment has been very elusive for the past 30, 40 years. You know, we had the radio frequency waves being used. We have tried all possible things. Right, Maipal?
Dr. Slade?
It's been very elusive to treat presbyopia with anything and everything.
I think that's the holy grail. Once we get there, that's going to be a big new horizon that ophthalmologists will be using. Yeah. I think we can go on to the next speaker since
Dr. Slade, did you have
Thank
you.
Yeah,
Dr. Slade?
Yeah, go ahead, Dr. Slade.
Great presentation. Quick question, Damien. How was patient comfort? Redness, stinging? You may have mentioned that, but I didn't quite hear it.
Yeah, so they do feel, I would say the side effect profile was mild, but some patients did get burning initially with drop use and some blurry vision, but surprisingly, with continual use of the medication, many of these side effects seem to get more tolerable.
Thank you.
More so than any other eye drop medication we prescribe.
Thank you. I think Dr. D has the presentation ready. Yeah. So we'll just go back to her, and that's astigmatism correction with a new aspheric abrasion-free monofocal IOL using intraoperative aberrometry. All yours. Look forward to a great talk. Yeah.
Thank you so much. If you'll just start that on, thank you. Thank you. I'm sorry for the confusion with my slides. Anyway, thank you all so much. This is an honor to be with all of you and to be part of this Indian Refractive Society meeting. I'm so excited and honored. These are my, if you'll go to the next slide.
Admin, next slide, please.
These are my financial disclosures, which aren't really related, except that I do use some of the equipment, but they were not promoted in this or paid for in this presentation. Next slide, please. So this is a new hydrophobic acrylic material that's new to the United States. Its parent lens was the MX60T. It's an aspheric optic, which has constant power from center to edge. So it doesn't introduce any spherical aberrations. It's a hydrophobic acrylic, glistening free, and on this form, it unfolds about 25 seconds in about 25 seconds, which is a lot faster than the other. And it has a very broad haptic, 110 degrees in the bag. So it really centers nicely and it really eliminates any rotation. Next slide, please. And these, scientists that do this are so amazing because all they did is they made a small increase in the percent by weight of the PEG-PEA component and a small decrease in the percent by weight of the styrene component. And what this allowed the lens to do was to open very quickly and us to be more efficient in the operating room. Next slide, please. So this is just the old material and the new material. And this was actually the first global implantation in November of this past year. And it opens so quickly through a 2.2 incision, opens so quickly through this incision that, it's almost upside down. So I had to flip it over, and still by flipping it over, it's still opening much more quickly than the old material that's right next to it. So now I'm aligning it with the Lensar and teleaxis marks and with the Aura. And before I can even get it aligned, it's nice and open. Next slide, please. So this is, if you'll click the video, this is again just the lens going in. Click the video so it runs on the picture of the eye. Anyway, this is just showing the screenshots from Aura and how nicely it aligns and how quickly it opens. If you look at the Purkinje images, they're nice and straight and aligned, so you know that the lens is not tilted or misaligned. And I rotated it to get less than a quarter diopter. Next slide, please. This is just showing the same thing, just how quickly it unfolds and how easy it is to manipulate and place on the correct axis. Okay, next slide, please. So I wanted to share with you my last 103 MX60 ETs. And again, what we are, worrying about so much for me is safety and efficiency in the operating room. And in this, there was no iatrogenic scratches that were made from the inserter or the forceps, opened in about 25 seconds, no glistenings and no posterior capsular fibrosis. And if you look at the first 103 patients, 95% were within a half and about 60% were within a quarter. Next slide, please. So this is interesting here. If the nice uncorrected distance visual acuity and, 75% were 20/20 without any correction. Next slide. And if you just click that slide, this is what was surprising. Just click that. Is the intermediate vision. 86% of these patients were 20/40 or better intermediately, and almost 60% were 20/25. So these patients with a monofocal toric lens could see their handheld phone or their their watch, all kinds of stuff. So it was pretty impressive that this monofocal toric actually had intermediate vision. Next slide, please. And that again just shows how the I was surprised with 86% having intermediate vision of 20/40 or better. Next slide, please. And near wasn't quite as good, and you wouldn't expect it to be, but still about 62% had an improvement of near vision uncorrected with this monofocal toric lens. Next slide. So also what's really great about this lens, the defocus tolerance. You know, as we know, theoretically, every line that we miss by a quarter diopter of our target refraction lowers the line of vision that we can see. So this gives you a very consistent broad range of vision across with residual MRSE. Next slide. And this is showing an eye trace that just shows a great increased depth of field. This is giving the patient about a diopter from intermediate, near, and distance. Next slide, please. So in summary, this opens quickly. There's a new preloaded version that will make it easier on our reps, or I mean on our scrubs. And I used it for the first time last week. It has a hard surface again and no glistenings. It's an aspheric, same power from center to edge, so it doesn't affect, it's not affected by centration or tilt. No introduction of high order aberrations. It's my go-to lens. It's great in zonulopathies and post-refractive patients, and it gives us a little extra bump in intermediate vision. Thank you very much.
Thank you so much, ma'am, for giving us a wonderful presentation. And thank God your slides open and wonderful. Any questions from the panel?
Could the admin stop the screen share, please? Any comments by anybody? Okay, one question to you. Why does it, what is it, is there some, why does it increase the depth of focus? Why does it give intermediate vision?
Well, you know, we're really I'm trying to figure that out. I know George has worked and Carolina has worked with this lens as well. And I think it's with the broad haptics and where it sits in the bag. I think it just gives us, in the material, I think it just gives us a nice depth of focus. And you know, I haven't found out the magic fairy juice. If I could, I would sell it as a premium lens if I could guarantee patients with near vision and intermediate vision. So we're still working on that, or I'm still working on that.
There is no progress of the dioptric power toward the periphery. It's just the same monocular.
It's the same power from center to edge. So it, you know, doesn't induce any spherical aberrations. It's zero.
Okay, so but I think they improve in but I think they improve in this range, at least, you know, from the perspective of the aberration. It's because of being aberration free. It doesn't cancel out the central corner aberration. I mean, we did a study with another model of that a couple of years ago,
right.
An IOL made by Bauschlom. And that is one of the main points. And another very important point about this IOL is the possibility to use it in patients that had hyperopic LASIK.
Absolutely. And this is, you know, this is a Bauschlom lens, and it is, all of their platforms are, you know, aspheric from center to edge. So it's great in hyperopic LASIK, and it's great, you know, it's my go-to lens. RK patients, it's really nice because it doesn't induce anything on an already aberrated cornea.
Okay. Thank you very much. Let's move on to the next talk. Yeah. Hi, George.
George here. I think the reason you have the increased depth of focus or field is because you're using the corneal spherical aberration, which is 0.3 with this 0 spherical aberration lens. So that 0.3 gives you about 3/4 of a diopter to a diopter of depth of focus, which is what you're getting. So by leaving that corneal spherical aberration there.
Yeah, some patients even more.
Well, again, depends on the corneal spherical aberration, I think, and their pupil size. So if you have patients with pupil size less than 3, you're going to get greater depth of focus, and people who have, you know, a pupil of 4 or 5 will get less. So it's that combination.
We published in American Journal one eye with this aberration free, and the fellow eye with negative spherical aberration, also a spherical IOL, and the intermediate vision was better with the aberration free, exactly by the reason why George Baker was saying. It's because they are using the corneal aberration to expand.
Absolutely.
You know,
yes, I did a similar presentation at AAO several years ago using a negative aberration and this precursor.
It's a very good presentation, B.
Thank you.
Thank you very much, Dr. Stevenson. Excellent presentation. We go on to.
Thanks for your help.
Thank you very much. Now we go on to Dr. Ralph Chu, and he'll be talking about presbyopia management. Dr. Ralph. He's from Minneapolis.
Thank you very much. Thank you very much. I'm going to try to just cover some of the technologies we've been involved with in our approach to presbyopia management. Many of these are technologies that are on the horizon and currently in clinical trial in the United States. What we found when we're managing presbyopia patients is that it requires a different mindset. This is a chronic progressive condition that we all will suffer from, and the procedures act sort of as a bridging technology from readers all the way to the final solution of an IOL currently. And so when I think about what's available, I think sort of from outside the eye to inside the eye. Dr. Goldberg talked about some pharmacological therapies, and we'll kind of cover some of the corneal, scleral, and lens options that we've been involved with. Dr. Goldberg talked about the accommodation and pupil effects. There are 3 trials, drops that we're familiar with, and like he has nicely delineated, these technologies work very well, tolerated well by patients. We're involved in the clinical trials for both the Allergan and the IIRSI trials, and these patients are incredibly happy. One interesting drop that's on the horizon is this EV06 drop, lipoic acid choline ester. It's a prodrug that's broken down by the enzymes in the cornea and actually breaks down disulfide bonds. And this creates a softening of the lens and actually an improvement over time in uncorrected near visual acuity over 90 days. And you can see from this graph that patients improved, and about 82% of patients achieved 20/40 or better vision, greater than placebo. So this is something that is in very early stage, but something on the horizon that is very exciting to us. We know about corneal inlays. We know about the aperture inlays for corneal treatments. There's refractive corneal inlays, and there's pluses and minuses to those technologies. But there's an interesting technology that's been in clinical trial in Europe right now. These slides are courtesy of Dr. Kilic, and she was the first to implant this allogenic corneal inlay here, made from treated corneal tissue. It's placed under a LASIK flap currently. And you can see that it's very, very clear as it goes under the LASIK flap. And when we look at it on post-operative, it's very difficult to see at the slit lamp, but there is a curvature change of the cornea and improvement in near uncorrected visual acuity with minimal reduction in distance acuity. So this is a central curvature change, which we would expect from an inlay. And here's an OCT showing the inlay under the LASIK flap. So again, this is another exciting technology from Allotex that is in current clinical trials in Europe. I'm not going to spend a lot of time on the corneal treatments of presbyopia. Many of these are not available in the United States, but we know Presbeyond is available outside the United States, and some of these other technologies have been tried to reshape the cornea to try to help improve near vision. We've been involved with the scleral implants, and these have evolved from their first generation to the current generation, and there has been an improvement. I mean, many of us were cautious about introducing this technology with the older techniques, but now there's a docking station, there's an automated tunnel creating device that creates very consistent depth placement of these incisions in a safe way. We can actually even do this outside the US through the conjunctiva without any major conjunctival opening, as you see here, the technique done in the FDA trial. This is progressing nicely through the clinical trials with the new technique. You can see in the green line here that a significantly greater percentage of patients received better uncorrected near visual acuity compared to the older scleral implant techniques. And when we look at our individual data, because we're unable to look at the aggregate data, you can see that a large percentage, 96%, achieved J3 or better at 18 months. And these patients are very happy. We're not operating in the visual axis, so it's a very safe procedure. They achieve really good distance vision, very early, and then their near vision actually stabilizes very quickly in the recovery process. So this is going through FDA trial, and that's something that we hope to have available to us soon in the United States. There's a lot of activity on the lens side. I'm just going to try to do a quick overview of some of the things we've seen. We were involved in this bifocal study from Lens Tech. It's a 5.75 millimeter optic hydrophilic acrylic lens. And you can see it has a bifocal segment on it with a distance segment and a small transition zone. It's a plate haptic design, and you can see here uncorrected distance visual acuity binocularly was unaffected compared to control, which we would hope for. But you can see a significant improvement in uncorrected near visual acuity binocularly at 1 year, the green being the study lens, and then the control being the blue line. So you can see a significant portion, really good percentage of good near vision. You can also see excellent intermediate vision with this lens. So this is, again, in the FDA clinical approval process, and hopefully will be available soon. Many of us are familiar outside the US, the aperture lens from AcuFocus is available. This is completing FDA clinical trial. We are one of the investigative sites here. One of the exciting things about this lens for me is not just the depth of focus, but that it also is incredibly tolerant to deviations from intended refractive target, including astigmatism. And you can see here that because of the aperture design, Dr. Goldberg talked about it with the drops, but the aperture design gives an increased depth of focus, but it also gives tolerance to astigmatic correction. And so it's not just a lens that's good for presbyopia, but it's also for these difficult corneas, post-refractive corneas, keratoconic corneas to treat these eyes. So something, again, very exciting to us. We've been involved in some of these new extended depth of focus lenses, accommodating not multifocal. So it's a sort of a smooth optical surface, but designed to sit posteriorly in the capsular bag. This is the Cord SC9 lens that's designed to sit very close to the nodal point of the eye. It's sort of, to me, the next generation of a crystal lens sort of platform. It is invented by Dr. Stuart Cummings. The clinical trial results look really excellent. You can see uncorrected acuities for distance, intermediate, and near are excellent. These patients are very, very happy. They achieve excellent near vision without any really compromise in distance vision very, very quickly in the process. And so this is
short of time, if you could.
Yep. I just have a few. I'll just go through. So, and then we have the shape-shifting optic lenses. We have the Power Vision lens that shows accommodation. We have another one from Juvene that is a 2-stage process. Dr. Stevenson and Slade are actively involved in this technology. And then Dr. Stevenson's on the advisory board of the Atia Vision lens, another modular design, optic shifting accommodating IOL that fits in the capsular bag. So just to conclude, the latest exciting technology that we're involved with is this Perfect Lens, a refractive index shaping technology that has the ability to reshape any acrylic lens to either a multifocal, just refractive error, progressing nicely in human trials outside the US at this time. So I think, there's a lot of exciting technologies in presbyopia, and I appreciate you letting me share some of our experience. Thank you.
Thank you. That was a wonderful insight, Dr. Chu. I mean, fantastic. So much is being done about it, and thanks so much for sharing what's coming in the next few years. And we'll keep some discussion a little later as we are running short of time. I'd invite Dr. Stephen Slade. Dr. Slade, are you there? For the light adjustable lens. Dr. Slade? I just saw him a little while back. I think.
Dr. Slade, you need to unmute yourself, please.
Okay.
Dr. Slade, you are muted.
Okay, unmuted.
Okay. Yes, let me introduce Dr. Slade. He needs no introduction, actually, but let me have the honor of introducing him. He is a specialist of presbyopia correction and cataract surgery, LASIK, and implantable Collamer lens and refractive surgery in Houston. I have my sweet memories meeting him when I was young and doing my retina fellowship with Charlie Garcia at Herman. And he was with Dr. Berkeley, and he was there, and a lot of insight which he gave at that time. I remember him getting the summa cum laude at Guy's Hospital in London. Welcome, Dr. Slade. Let's hear what you have to say on the light adjustable lens.
Perfect. Are my slides coming through there?
No.
Not yet.
Okay, I've picked share screen. Share.
Yes.
Yes.
That's done.
Yeah.
That's done.
Okay, super. Okay, thank you very much for the introduction, and thanks to Amar and Ashvin for inviting me. We were Wish we could be in India. We had the whole family lined up to go. The girls, we've been banned in several countries, so we were hoping to see how long we would last in India. But we really do miss all of you. So, a lot of this, we've talked about refractive surgery, many thanks to John Doan. He actually shepherded me through LASIK. That was good advice, but it's good procedure. But, certainly in the United States, our patients are aging. And so what we're really looking at is treating older patients either for presbyopia or we're treating them for cataracts. So I'm becoming more of a lenticular refractive surgeon than a cataract refractive surgeon. But one thing I learned in LASIK, and my gosh, those lessons were so valuable that we learned in LASIK, was that uncorrected distance vision is what these people are after. That's what drives satisfaction. The better vision they get, uncorrected, the happier they're going to be. So accuracy and quality of vision are absolutely key in anything we do. Now, in lens-based surgery and cataract surgery, refractive lens exchanges, we have this thing, it's not a calculation. We are estimating a lens power because we have this ELP fudge factor that we don't know what it is. So I tell my patients we're going to estimate a lens power. And unless you have a PhD and a supercomputer and a weather station, most of us don't get, for a lot of our patients, within half a diopter. And that's just the truth. That's not the accuracy that makes people satisfied. They had better in LASIK. So after surgery, after you do lens surgery, sure, there's a lot of options, whether it's LRIs or exchanges or LASIK or glasses, but there's also a lot of talking, a lot of FaceTime, a lot of visits, and that's not really what they tend to be after otherwise. Then, what about these patients? Remember, your patients that have come to you and had LASIK or whatever, they're likely to be the patients to come back to you earliest for refractive lens exchange. You've already helped them once. Maybe not this patient, but a lot of them you've helped. So which formula are you going to use for this fellow, this eye? Which axis are you going to put your astigmatism? And remember, you have to decide all that before you operate. It's like betting on something before you see the odds. It really is. So that's why, that's why I say post-op is the new pre-op. And monovision. Everything that we've talked about are wonderful possibilities. But right now, what is your number one option for presbyopia, unless you sell readers? Our number one option for presbyopia is monovision. It truly is. How are you going to find out if this patient tolerates monovision? How will you fine tune it? How will you know how much to back off the dominant eye? How much anisometropia they can take? So that's the light adjustable lenses role here. And I think you're all familiar with it. It's amazing chemistry inside of a lens where you use regular light after the implantation to alter. It's fully FDA approved. It's more than half our volume now here in Houston. John Doan was an early pioneer with it. It's really quite a remarkable. It's very much a surgeon's lens. It's a silicone 3-piece IOL. Abbey numbers are the best. You don't get a better quality of vision than a monofocal, which it is, silicone IOL. You can put it in the capsule or the sulcus, which you cannot do with our acrylic lenses. It certainly is the easiest to exchange because of the haptic designs and because it's silicone. Exchanges are something that you have to be much more comfortable with and much more willing to do if you're going to do refractive lens exchanges. People say, well, gee, silicone opens so quickly. And I say, gee, silicone opens so quickly. You don't have to sit there and pick haptics off or worry about that. It's 2.75 wound. We're working on getting that even smaller. Certainly, it has the easiest pre-op planning. We go through every single thing we can to estimate the lens power, but we have a second chance. And we don't have to do anything about the toricity. No marking, no orientation, no power on that. We put it in. That's all done. And as far as the results, and I'll speak about that in a minute, are fantastic. Standard cataract and all. The FDA study results were excellent. In fact, if you look at toricity, residual astigmatism of this lens compared to a toric IOL, FDA results to FDA results, it's about 2x. There is nothing better for toricity, astigmatism, than this. This is the light delivery device. It is a piece of hardware that you do have to purchase. It's 2, 3, sometimes 4 visits. Your technicians can do this. You can do this. The applications are about a minute, minute and a half. It's light, and just the UV portion of that light is what affects the lens. So to summarize, it really is post-op now in our clinic is the new pre-op. It is a procedure for patients that we don't hit precisely rather than a surgical option. So we say we're going to, it's basically like doing a YAG to them rather than doing a PRK. Think of the difference of that in their minds. You don't have to do the worrying of putting in the wrong lens, which at least in the United States is the #1 cause of lawsuits. People think you put in the wrong lens. It's a clear path for monovision. There is extra office work. You do have the patients come back more often. You do have this YAG-like, to the patient's perspective, procedure that you do, but everything is done post-op. Even dry eyes. You know, we talk about optimizing corneal surface for dry eye. Well, really, when you want to optimize the surface is post-op. So what we're doing now, rather than telling a dry eye patient, gee, your cornea doesn't look so good, we're going to cancel your surgery and we'll see you back in a few weeks. We say, we're going to go ahead and do the surgery. And then as we're adjusting or before we're adjusting, we'll get your cornea in good shape because it's more relevant. It's more important to the adjustments we make their corneal surface rather than the actual estimation of the lens power. There is an EDOF version on this. The early results are very good, but that's another talk. Thank you very much.
Thank you, Dr. Slade. Quite a few questions, but I'll come back to you because of lack of time. I invite Dr. Mahipal Sachdev. Let me introduce a dear friend of mine, a very respected colleague in the country. He did his undergrad, postgraduate from the All India Institute of Medical Science. He's the chairman, clinical director, and a business entrepreneur, surgeon par excellence, has so many things to be talked about. I welcome Dr. Mahipal to give his talk on single pass 4th-row pupilloplasty in phakic eyes.
Thank you. Thank you very much, Himanshu. Are my slides on?
Yes. Okay.
Thank you very much. I'll be talking about single pass 4th-row pupilloplasty. Now, the idea that was propounded by Amar Agarwal was the 4th row, but then one of the prerequisites that he had was that these could be done only once the eyes were made aphakic, and otherwise there was the problem of the needle or the suture needle damaging the lens. So what we have done as regards the change in this technique of pupilloplasty is to kind of get the safety net for the patients who are phakic and yet need a pupilloplasty. So this is what exactly we are going to do as to how we are going to look at these very techniques. Now, this technique is in press in the Indian Journal of Ophthalmology. Let me come to two specific cases. 24-year-old male who presented with complaints of glare and difficulty in near activities because the patient had a accident and a cricket ball had hit him, and the vision otherwise was improving to 20/20. There was a traumatic mydriasis that you could see, but the lens was clear and it was a clear crystalline lens. Fundus evaluation was normal. And apart from the traumatic mydriasis, the rest of the examination was unremarkable. Now, how would you want to go ahead and reshape the pupil without having the damage to the lens that is there? So this is the IOL scaffold 4-throw pupilloplasty. 4-throw, as you all understand, is to have it thrown 4 times so that you don't have to go back again to tie a knot again. Now you can see this is the patient who has a traumatic mydriasis, as you can see in this particular case. And the pupil, there are a lot of areas where there is sphincteric tear, as you can see, because of the injury with the cricket ball. So what we are doing here is to make the side port incision, the main port incision, fill it up with viscoelastic. Now in this particular case, what we did was we took a plate lens. So a plate intraocular lens was taken and we just injected, trying to put it into the anterior chamber rather than pushing it below the iris. And you can see that we are letting it open. A plate lens is taken because it will give you a larger area, and the axis you have to determine as to the plane of the axis you can put, so that wherever you are going to pass the needle, it should have the largest area that is there to give you a scaffold. So it is like a IOL scaffold for the needle. It is for the pupilloplasty that you have. Now you inject viscoelastic again. And now we start on with the second incision that we have, and we will go in and do the pupilloplasty. So if you did not have this lens, you could actually injure the normal crystalline lens. So this is just the normal, we are holding it. We are going in with a needle from the other side. As you can see, we go in from the needle and we thread this needle onto the 26 gauge needle that we have into it. And we can therefore go ahead and remove it out. So see the safety net that we have created in this particular case. And this safety net is by anything. It could be an intraocular lens, plate intraocular lens, or you can use an IPCL or an ICL, etc. So it will just be because you have to waste this lens. The cost would be the only thing. So ICL being a little more expensive. So before we tie the suture, we will just rotate out the lens. And you can see that we are just rotating out the lens, and we will remove this lens, and it comes out very easily because it's a soft lens, and you can just pull it out from the same incision. And now you go back in and just need to tie the suture. So the main time when you could have an injury onto the lens, the crystalline lens, at that time you have the advantage of an IOL. So let me just go, because of the paucity of time. The post-operatively, the pupil was well-rounded. There was no significant endothelial cell loss, and the patient improved. So this is the treatment that you have. If there is an iris dysfunction, it is aimed at restoring the pupillary aperture, thereby reducing the disturbing light that is entering the eye. And apart from the functional and aesthetic issues, anisocoria can impact the psychological aspects of the individual. So this technique that we have described can be used in phakic eyes also. And the intraocular lens can be replaced. As you can see, this is the picture you have. In this particular case, we used a ICL. The ICL will be vaulted upwards, and the gap between the ICL, which the IOL is not vaulted, would again give you a still more safety net that is there. And even if the ICL won't touch the lens, so you can go ahead and do this particular case by using an implantable polymer lens also. The only thing is that whether you are using an intraocular lens, it has to be a plate lens, or whether you are using an ICL, you'll just need to throw that away, and that's the cost factor that will be involved. So SFT 4 throws is with an intraocular lens scaffold or an ICL scaffold is a safe and effective way of reshaping the pupil even in phakic eyes. And this scaffold technique can also be combined with other pupilloplasty techniques to give you optimal results. Thank you very much for your kind attention.
Thank you. fourth row pupilloplasty has revolutionized actually high amount of astigmatism, all kinds of trauma through the pupil with a very simple technique. Thanks for going in so much detail and using the scaffold just to help us grasp the iris. We are short of time. I've done one question for Dr. Stephen Slade. It's a silicone lens. We thought we had almost given up silicone lens. And you said this lens, the light adjustable lens, would be a silicone lens. Would you like to say something about that? And what is the timing of giving the light, UV light, following the surgery?
Right. Okay. Thanks. Two questions. The silicone, it is silicone, no question. It has a polymer in it, but it is basically silicone. But, silicone is the most implanted substance into the body in general that there is. It's certainly one of the least reactive. It also, as I mentioned, it has the best Abbey values as far as quality of vision. It has a lower refractive index, so the incision has to be a little bit bigger. The lens has to be a little bit thicker. But after years of doing all acrylic, half our volume now is this lens and half the volume is in acrylic. I like it. I like the silicone. It just gives, again, it exchanges easily and gives a very good quality of vision. Now, the timing of the light adjustments, we do the first one about 2 weeks, 1 to 2 weeks afterwards, giving them a chance to stabilize a bit. And then they can have anywhere from 2, but typically 3, up to 4. I think the max I've heard of was 5 adjustments, usually 5-7 days apart.
Very nice.
Thank you. Thank you so much.
Thank you. Thank you very much. Thank you, Himanshu.
John has been quiet.
Yeah. Yeah. Thank you very much, Himanshu, and thank you very much, Ron, George, Shiraz, Dr. Santiago, and all the speakers for this. I think we overshot the time. And Amar, what do you have to say about the first session of IIRSI?
Thank you very much, Mahipal and Himanshu. Himanshu, as many people who are joining in, just remember, Himanshu has taken over as the president of the IIRSI. And as everyone knows, Mahipal is the chairman of the committee. I would like to thank the panelists and the speakers for the first session. And we'll move on to the second then. And I'd like to, before I start the second symposia, I'd like to tell those who are the first symposia, can you go off the videos and log out from your system, and you can watch it on the IIRSI.com website, the remaining sessions. Now, coming to the second symposia, which is the ISHF symposia by covering up the glued IOL and the Yamane. There are two people who are so close to me, and I thought there's no one better than them to conduct this symposia. There's someone who's so tall and his heart is so big, and there's nobody taller than him. And I don't think they'll have a heart bigger than him. And that's none other than Eric Donenfeld. And look at his surgical skill. I lost count of the number of centers he has all over in the United States. And the volumes he does is phenomenal. So the first person I'd like to talk to you about is this person, Eric Donenfeld. And the second is another very dear friend of ours, Mohan Rajan, who is the treasurer of the IIRSI. Mahipal, over to you. Few words.
Thank you very much. I think it's a pleasure to welcome Eric and Mohan and all the panelists, George Beko, we have Yuri, we have Gerardo, and we have Naveen Rao. I think it's going to be a great session. Amar, what have you been doing during this COVID time? Have you developed something new as regards home health, home care, anything to do?
Well, we decided to work on a new machine which we have created, which is a virtual autoperimeter. It is called the Advanced Vision Analyzer, marketed by this company called ELISAR. So it has also got a US FDA approval, and you'll see this being talked more about in the symposia. But basic idea is it has at 1/5 the cost of the normal Zeiss perimeters, and it just puts it on like this, and you have a full virtual perimeter. So that's what we are working
going on in Hall D now, Amar.
Lovely.
So I think all the speakers, all the panelists will get one of these perimeters free of cost, shipped by Amar tomorrow morning. So anyway, I think let's pass it on to Eric and Mohan for the next session. All yours, Mohan and Eric.
Thank you.
Nice seeing you.
Before we go ahead, we just have a sponsor video. Sir.
Okay.
Sorry. Good. So we'll have the sponsor video.
Good evening, all the speakers. Panelists.
Very good.
Hello, sir.
Mohan, how are you?
Fine, sir. How are you, sir?
Very good, thank you.
Yes, sir.
I think we're ready to get started. Would you play it from the beginning or it's done? Okay. All yours.
All yours, Mohan.
Quick video. Yeah. Thank you very much. I think it's a beautiful session. It's going to be very interesting. We're going to cover the golden triad of intrascleral haptic fixation, glued IOL, and the Yamane technique as well. Along with me, co-moderating this wonderful session is none other than Eric Donenfield, and he doesn't require any introduction. I also want to say that we have broken all records as far as the webinars are concerned. More than 130 countries and more than 9,500 registrations, and it's counting. It's going up every minute. I think hats off to Amar and his team, the IIRSI, for making this a huge success. Over to Eric Donenfield, sir, for introduction, sir.
Very good.
Yes.
Well, very excited about being here with all of you today. I really want to thank Amar for putting all this together. I want to thank all the participants. I always find that this meeting is one of the meetings where I truly learn more than any other meeting that I attend, and I always appreciate the hospitality. I wish I was there with you today in India, but I'm here in New York, and I'm going to be speaking about glued IOL tips and tricks. And if there's any procedure that has really changed the way I practice in the last decade, it's been Amar Agarwal's invention of the glued IOL. And I've given up almost completely suturing IOLs and all types of different procedures. I find this technique to be my go-to procedure. As a matter of fact, Amar, I did 5 this week in my office, in my practice. So without further ado, let's get started on glued IOL tips and tricks. Let me just go to slideshow. And it's a very simple procedure, really, with a lot of small steps. All the steps have to be done well. The glued IOL technique starts with the conjunctival prudomy, making certain that you're 180 degrees apart, and you can use a toric marker if you like to make certain you're in the right place. Little things like making certain that you dry the sclera well. You don't want to have blood leaking into the eye during the procedure because, again, this case is all about visualization. It's about seeing what you're doing. The scleral flap is made by using a crescent blade and just opening the sclera. And this is a very easily performed procedure. And once you've made your flaps, we want to place an anterior chamber maintainer and then enter the eye. As far as IOLs are concerned, I like to use a 3-piece lens. The Zeiss lens is really my favorite, but it's hard to get in the United States. So a lot of times I'll use a Bausch & Lomb or an AMO product. I make a pars plana vitrectomy 2.5 meters behind under the scleral flaps, and do your vitrectomy, making certain you're not pulling on the vitreous base. And this is performed with a moderate vacuum, but a high cutting rate. The key to the procedure really is inserting the IOL. I like to insert the IOL, and this is a place where it really helps to have a second pair of hands. I'll put the lens into the eye. I want to grab the haptic. And it's really important, as Amar has taught me, to grab the haptic right at the edge. If you grab it in the middle, you'll actually bend it and make it more difficult to place. And now comes the hand check technique where you pass the haptic from one hand to the other. Again, grabbing the haptic right near the very edge and pulling out through the pars plate incision that you've created. At this point, you can really let go of the haptics. There's no stress on it. It's going to adjust very nicely. And then you tuck it into the sclera. I like to use an MVR blade to do this. You can use a 15-gauge needle as well. Many times I'll stain this with a gentian violet to make sure I can find my location. And once it's in place, you can adjust it. You can push or pull it to make sure that the IOL is well centered. And the beauty of this procedure, and the reason it has become my preferred procedure, is that the lens tends to center very well with no tilt. Next, you apply the glue. You smooth out the scleral flap. You smooth out the conjunctiva. and the procedure has essentially been completed. The lens stays in place very nicely. It's well fixated, and it's well centered with almost minimal tilt. So again, my thanks to Amar Agarwal for bringing us this wonderful procedure that has really changed the way I manage secondary IOLs in many of my patients. Thank you very much. That concludes my talk. And at this point, we can turn over to our next speaker.
Thank you, sir. Shall I share my screen, sir? And then after that, we'll go on to the panel, because my my topic is also a similar one. Are you able to see my screen, sir?
Yes.
Let me thank Amar Agarwal and the IIRSI team for the wonderful opportunity. And also we'd like to, I forgot to introduce the panel, the expert panel here. We have George Bacco, Yuri Meki from USA, George Bacco from Canada, Gerardo from Argentina, and Naveen Rao from the USA. And they'll be discussing on this various topics, various interesting topics as well. So I'm going to talk to you on something like a repetition of what Eric told just now. These are my financial interests. If you have a PCR like this, then there are different options. Okay, there are different options like ACIOL, sulcus fixated. If you have sufficient capsular support, then you have a scleral fixated. Then you have the iris fixated lens, retro iris cloud lenses, and then we have the glued IOLs. Glued IOL, as you know, described in 2007 by Amar Agarwal. The glue magic, the top 7, I'm going to take you through. Special instrumentation, you have the need a trocar and cannula or an AC maintainer, the crescent knife and the fibrin glue and the micro forceps, which is made by Indian companies like Epsilon as well. Then you have the important, the 2 glues which are available, one which is made by Baxter, another made by the Reliance company, which is called the Tissel, which is made by the Baxter, which is combination of thrombin and fibrinogen, which is very, very important. Number 1 trick, as far as this thing is a scleral flaps, either you can make triangular, rectangular, or groove. You can see this is a triangular, the rectangular flap, which is made 0-180 degrees. That's very, very important. You can use a radial keratotomy or the Ashin Agarwal marker, know exactly where your flaps are. 0-180 degrees, very, very important. Then I have developed a technique which is the triangular flap. You can see here the triangular flap, which we make in trabeculectomy, which you are more familiar with. So you can do the triangular flap as well, or you can do just a scleral groove if you don't want to make a scleral flap, and tuck the haptic in the crevices of the groove as well without making a flap. But there is a little more learning curve in that. Number 2 is the whole ball game as far as the glued IOL technique is concerned is not with the viscoelastic. It is the fluid inside the eye. The fluid can be in the form of a pars plana. If you are apprehensive of putting a pars plana trocar and cannula, you can use an anterior chamber maintainer as well. Only thing is you need to make sure that the eye is very firm before you put the trocar and cannula into the pars plana, measuring about 3.5 millimeters from the limbus, or you can put a anterior chamber maintainer, which is very, very familiar with an anterior segment surgeon as well. So you can put an anterior chamber maintainer which snugly fits into the this thing, and they can go ahead with the glued IOL as well. Just number 3 is sclerotomy underneath the flap. This is again very important. Once you put the anterior chamber maintainer, the pars plana infusion, putting a sclerotomy, making sure that the myringotomy knife is directed towards the mid-vitreous cavity and not touching the iris. If you go anteriorly, you might produce a problem in the iris or produce a iridodialysis as well. Number 4 is complete anterior vitrectomy. Always use tricot to remove all the capsular and cortical remnants. You don't want any capsular cortical remnants in the pupillary area. You don't want any vitreous to entangle in the crevices of the glued IOL. It's very, very important to always use tricot, because as you know, vitreous is a colorless substance. Use preservative-free diluted tricot and make sure that you remove the capsular cortical remnants as well as the vitreous, which is there in the anterior chamber. Number 5 is externalize the haptic, which is very, very important. Always use a 3-piece foldable lenses, multi-piece lenses, or you can use a rigid lens if you're going to extend the incision. Catch the tip and handshake technique is very, very important. Eric rightly mentioned that. Always look for the lucky 7 sign. Look for the lucky 7 sign. That is the haptic coming out. And once the haptic comes out, don't try to pull it out at that time. If you try to pull it out, the haptic will break and the whole battle is lost. always try to catch the tip and hold the tip there. And ask your assistant to push the lens, and slowly, as the lens comes out, try to pull that lens or the haptic outside through the sclerotomy, as well as this is a handshake technique wherein the trailing haptic is done with the trailing haptic with the glued IOL forceps as well, and that makes the game very simple. Number 6 is tucking of the haptic in the tunnel. This also Eric mentioned very beautifully. I use a 26 gauge needle. I always stain that with the methylene blue to make sure that they know exactly where the tunnel is, then tucking it. And that is the advantage of the glued IOL. You can tuck and untuck on one side so that you know exactly what is the tightening and the loosening procedure as well. Unlike the Yamane technique, it is straight underneath your vision, and you know exactly how to tighten the lens, how to stabilize the lens as well. So these are the tightening procedures. And number 7 is application of the glue on the dry surface. Very important. Making sure that the entire area is completely dry, then apply the thrombin and then the fibrin, and then close it for about 30 to 45 seconds. Close the scleral flap for about 30 to 45 seconds. Keep it completely dry. Make sure there is no, if it's wet, it will not stick. Again, you can use the glue for the conjunctiva as well. You can use the glue for the sclerostomy as well, and for the pars plana infusion if you're going to use, and you can use the glue. And for the corneal, this thing you can always put a suture if you want to. So these are the take-home pearls as far as glued IOLs is concerned. Scleral flaps 180-degree apart, pars plana infusion or AC maintainer, sclerostomies, complete anterior vitrectomy, externalize the haptic. Always use a 3-piece. I use a AMO lens or a Agrisoft lens. Tucking of the haptic is very, very important. Application of glue on the dry surface, and the glued IOLs will become a very, very easy job for you. Thank you very much for the wonderful opportunity. And we'll take the questions from, sir, for the first 2 topics from the panelists. Any comments are there, and then we'll go on to the third, that is the Yamane technique.
So panelists, comments about the glued IOL. You mentioned before that you like the AMO and the lens. The CT Lucia lens from Zeiss is a very flexible haptic, and that's the lens that I tend to prefer if you can find it here in the United States. George, what lens do you like to use in Canada?
George.
Unmute yourself, George.
George, yeah, yours. Please unmute yourself.
All right, thanks. I use the B&L Soflex, the Li61 SE, and that seems to work quite well for me. I've also, I mean, if the lens is there, a dislocated lens, I'll try and use a lens that's in place. So I've had dislocated 3-piece Technis lenses that I've been able to do this with, and I've had some limited luck with a 3-piece at PMMA haptic. So, but those are probably the hardest to use.
Good. I like to use a lens when it's there as well. I find that the lens has been there for a long time. Sometimes the haptics get very brittle and they can break. So you have to be very gentle when you manipulate them.
Not only that, last week I had one where I pulled on the haptic and it came out of the optic, so had no choice but to.
Yeah, that ruins your whole morning when that happens, doesn't it?
Yeah, it's not a nice thing. The other thing is, I mean, we've published on this earlier, but when somebody's starting to do this technique, and in North America, we don't have the option of having techs that help us with the surgery that are familiar with the surgery. You can use silicone tires to hold the haptic out. So once you externalize that first haptic, take your silicone tire that you get from your iris retractors or pupil retractors and put it on that haptic so it doesn't slip back in.
Absolutely.
Okay.
That's a very good technique. Yeah.
Good pearl.
I agree.
Very good.
Good. Yeah. Any other comments from the panel?
The difference between the haptic, hello everybody.
Yeah, hi.
Is the material. The material of the flex haptic is PVDF, and the other one is Prolene. The PVDF haptic are like indestructible. It's impossible to break. It's good to begin this technique. Use PVDF haptics.
Absolutely, sir. Which is, I think the soft port AO has got the PVDF haptic. It is the Bosch and Lomb lens.
I don't know. In my country are 2 lenses. One is named Lisa. No, it's one of the PVDF haptics. and the other one is from India, but I don't know the soft lens.
The CT Lucia is the most flexible
Lucia, okay,
lens that we have in the United States.
Yes.
And again, the other ones are all Prolene. That's the only one that's
Unfortunately, that's not available in India, sir. Eric,
Eric, one comment. There is a company which is US based that's called Medenium, based in California. They don't have lenses available in the United States, but they sell them internationally. You may want to look into that. They do have 3-piece lenses with PVDF haptics of no financial interest.
Very, very good. So let's move on to our next talk at this point. And I can't think of a better person to talk about the Yamane technique than Shin. It's great to have you here with us today. So let's hear about Yamane tips and tricks from the original trickster.
Thank you for the invitation. Today I have a short talk about tips and tricks of the Yamane technique. This technique is very simple. Just insert 2 30-gauge C-more needles. I use a needle stabilizer to stabilize the insertion angle of the needle, but if you don't have, just insert the needle 2 millimeters from the limbs. Then the haptics are inserted into the needles. I just leave the first needle on the eyelid. So I use no assistant for this surgery. The haptics are externalized with the needles. And usually I cut the haptic 1 or 2 millimeters to make the IOL centered and avoid tilt of the IOL. Then make flange with cautery, and the flanges are pushed back and fixed into the square tunnel. Today's talk is 3 tips of this technique. The most important point is the positional relationship of the wound. The main wound for IOL insertion and the left square tunnel should be separated about 70 to 90 degrees. If they are too apart, you can't align the needle and haptic, so it's difficult to insert. You should align the haptic and the leading haptic to insert. For insertion of the trailing haptic, double needle technique is very important. If you externalize the leading haptic, it's very difficult to insert the trailing haptic into the second needle because the anterior chamber is very limited space. So placing the first haptic into the needle, then the positional relationship of the trailing haptic and the second needle appropriate, so it's easier to insert it. Making flange is not so difficult, but there are 3 points, 3 tips. Please dry up the haptic before making flange. If the haptic covered by the OVD, you can't make flange. So you should wash the OVD before making flange. And do not touch the haptic with cautery, it will adhere. So just make close so you can easily make the flange. Never touch the haptic with cautery. And the material of the haptic is very important. Previously, the panelists said, and the PVDF haptic is better for square fixation. I agree with them. Some PMMA material will disappear by heating, so you should make flange before the first case. you should recognize the shape of the flange is different between the different materials of the haptic. And please remember, you must fix the flange into the square toenail. Do not leave it under conjunctiva. It will move after surgery. If the flange is too large to fix into the square toenail, you should enlarge the entry side of the square toenail using some knives or needles. Then you fix the flange completely inside the square. So the Yamane technique is very simple, but there are many tips and tricks. Please remember some tips for inserting haptics into the needles, and be careful of pitfalls when creating the flange. Thank you for your attention.
Very good.
Lovely. I think the next talk is also on Yamane, sir. We can have the next speaker by Brian Kim, and then we'll go on to it. Am I right? Okay, sir. Is Eric, sir? Eric, sir?
Yes, Brian Kim.
Yeah, Brian Kim. Yeah. Thank you very much.
Hi, everyone. Can you hear me?
Yes, Brian.
Okay, and hopefully you can see my slides.
Yes, sir.
Okay,
Please
great.
Go ahead. Please go ahead.
All right, so I want to thank Amar and Ashvin for having me. I was in Chennai last year. I had such a great time, and I'm just honored to be back virtually. I'm sad that I can't see everybody, and hopefully we'll be able to see each other soon. And so I think it's a little presumptuous for me to be presenting Mastering Yamane Technique right after Dr. Yamane himself. And this talk is really for the mortals that have to try to do this technique. And so I'm going to rather call it my top 5 pearls to make Yamane easier. And so my top 5 pearls to achieve the keys to success with the Yamane technique. And so pearl number 1 is infusion. The problem is it's difficult to pierce the sclera with the needles when the eye is soft. And so you really need a large bore infusion, whether it's anterior or posterior. And this helps to stabilize the globe for easier and more controlled manipulation. Pearl number 2 is conjunctival marking and globe fixation. So the problem is without the marks, it's difficult to achieve accurate and precise scleral needle placement, which means higher risk for poor IOL position. And the other problem is marking the conjunctiva alone is not enough because the conjunctiva is a mobile tissue. And so you need to have the needle marks, the needle marks may not accurately reflect your measurements. And so the solution is to go ahead and mark appropriately, and then you have to fixate the conjunctiva in the neutral position with the forceps so the conjunctival marks more accurately reflect the desired scleral needle placement. So this is very important. And so this is illustrated with this video. So the trocar is held with forceps to stabilize the eye for the right needle here. And you can see the conjunctival marks are not distorted with the needle pass. And so that means the markings will actually reflect where you actually want to place the needle. Pearl number 3 is proper needle bending. And so the problem is the first haptic needle complex, it's when released into the vitreous space, can contact the retina. And so the solution is to bend the first needle to shorten its excursion within the vitreous space. But remember, the needles must be bent such that the bevel faces a haptic. And I'm going to go over that in just a moment why. So that's what pearl number 4 is, haptic docking technique. So the problem is the haptic is curved and the needle is straight. And this is why surgeons struggle to cannulate the haptic through the needle. Not Dr. Yamane, not the ones who are very experienced, but those of us who aren't as experienced. And so the solution is to dock the haptic on the bevel of the needle first, but don't advance, straighten the haptic against the bevel to slide it more easily into the needle. And remember, in order to do this, the haptic must face the bevel of the needle to facilitate the docking. And in this case, the left side needle bevel faces away from you, while the right side needle faces toward you, but the bevel always faces the haptic. So now this is the trouble with the trailing haptic. It's difficult to control the haptic when you're holding it too far from the tip. And also this is because the left haptic is tethered to the left needle. And it's harder to thread the right haptic and the right needle because the left side resists straightening of the trailing haptic. And so I developed the trailing haptic first modification. And so the solution is to externalize the leading haptic through a contralateral limbal incision to improve access to the trailing haptic for needle fixation. And so this is shown in this video. The technician advances the IOL, and the surgeon externalizes the leading haptic with microforceps. The trailing haptic is swept to the right. The trailing haptic is captured within the incision in a U-shaped configuration. The apex of the U is the ideal place to grasp the haptic for needle fixation. The bevel of the needle is used to dock the haptic, straighten, and then advance. The leading haptic is internalized with microforceps and placed into the angle. And similarly, the leading haptic is docked on the bevel of the needle, straightened, and then advanced. So in summary, remember the top 5 pearls. Number 1, a large bore infusion to firm up the globe. Number 2, conjunctival marking and globe fixation for more accurate and precise scleral needle placement. Number 3, proper needle bending to expose the bevel to the haptic. Number 4, haptic docking technique to easily pass the haptic into the needle. And number 5, the trailing haptic first technique to easily cannulate the trailing haptic within the needle. Thank you for your attention.
Fantastic. Can we have the discussion by the panelists on the Yamane technique? George, start with George.
Yeah, Shin, fantastic technique. And I think you've changed surgery for us in a very positive way. You know, your technique, once mastered, is a very handy tool to have. And Brian, you know, the most important thing I think I learned from you was trailing haptic first. I have to give you credit for that. I think that makes it much easier for people who are starting out to do the technique. And, you know, as you say, Shin can do this with his eyes closed. The rest of us need to struggle through it. And by doing that trailing haptic or non-dominant hand first, it really makes the technique much easier to do. So congratulations to both of you for you know, demonstrating a very nice technique that we can use.
Okay. Well, first, I usually say that Jean Yamane is a genius. It's one of the ophthalmologists that developed this technique. It's opened a lot of doors for all of the rest of ophthalmology in the world. Second, the trailing haptic, I usually insert in the needle while it's in the injector cartridge. It's easy for us. If you put the first haptic during the IOL is in the cartridge, it's easy. It's not necessary another maneuver, but no, it's all perfect.
Gerardo, I do the same thing. I feed the first needle and never touch the first haptic with the forceps, ever.
Yeah.
And saves us. And when you use the PVDF haptics, then you can really bend them back, get it into that trailing haptic into the needle, so that saves time. And so, yeah, thanks to Shin and all the other innovators for giving us such great techniques. Glued IOL is very versatile for lots of unusual cases or damaged eyes or something that's not normal. But when everything's normal except for the Yamane is what I call my fastball. That's what I'm gonna deliver every time. It's quick, it's fast, it's stable, and it looks good and centers well.
We just have a few additional comments. When burying the flanges into the sclera, I think it's important to lift the conjunctiva over the haptic to make sure that the flange actually gets through the conjunctiva, because sometimes it gets caught there and pulls the conj into the scleral tract, and it will never fully seat itself in the sclera. And so that's one concept. Shin showed a great pearl about the angle of the docking. I think it's important to move the haptic toward, to move the needle rather toward the periphery, to move the needle toward the haptic rather than moving the haptic toward the needle. So if you conceptualize moving the needle towards the angle for the first haptic docking, I think that can make it easier. And the final comment is if you have the AC maintainer or pars plana infusion cannula, cranking the pressure up to 35, I've found if you hit 35 with the pressure, it's much easier to penetrate the sclera and achieve a safer entry with the needle.
All good points.
Very true. Just make sure
I just
you
have
enter the eye, the
question.
iris is going to come out.
Yes, I just have a question to all this because I've been doing both the Yamane as well as glued IOL. But I find that in Yamane, the pseudo-phaco is little more than the glued IOLs. And the reason probably I thought was because you are making a flange and you're pushing it, you do not know how much of haptic is going and sitting there on the sclera. So at least in my study, the pseudo-phaco is little more than compared to the glued IOL. Glued IOL, absolutely, there's no pseudo-phaco. I want the opinion of the panelists as well as Eric also on this particular comment.
This is Brian Kim. I think that might be because if you don't have enough of a scleral shelf and you're more kind of perpendicular and you're going into the sclera, it's not providing enough platform on the sclera for the haptic. And in that case, I can see how that could happen. But as long as you have a nice 2 millimeter shelf of sclera for the haptic, that should be not an issue.
Okay, sir.
Yeah, I agree.
Probably I should try that, yes.
That's the reason.
We'll go on to the next speaker, sir. Eric, sir.
Okay, our next speaker, shifting from Yamane to glued in a challenging case, Ahmad Asaf, please.
Okay, thank you very much for the invitation. I would like to thank Amar Agrawal and Ashwin Agrawal for their invitation. I'm very sad. I wish I could be here in India physically, and this meeting, now with this meeting gone virtual. Anyhow, I hope you can see my screen right now. I will show you a video. This is a case of traumatic aniridia with a subluxed cataract, and this patient has gone for the posterior segment surgery for vitreous hemorrhage, and now he is presenting with subluxed cataract. These two-step surgery. The first step is to cataract extraction and do the Yamane technique for visual rehabilitation of the patient and fix the IOL toward the sclera, and then because of the logistics for bringing or importing the artificial iris, and this patient is coming from abroad, so we postponed the other step of artificial iris for 2 months later. So I started the Yamane technique, and this situation is very important, as mentioned before, fixing the AC maintainer, and now I did the lensectomy. This eye has been fluid-filled, vitrectomized, is not silicone-filled, fluid-filled, and now I'm starting to implant the 3-piece lens inside the anterior chamber, and all of a sudden I found I don't have enough iris tissue to support the leading haptic inside the anterior chamber. How foolish I was at that time. So I asked assistance from the nurse, but the nurse was the first time to help me, and she was not confident she can do this for me. So I had to proceed without any assistance. So I hold the lens. I'm trying to find how can I leave the lens, the leading haptic, to be supported inside the eye. And you can see here, even with the struggling, the anterior chamber maintainer has been locked outside the eye, and the situation is getting softer, and I had to replace it again, and then trying here to place the leading haptic to the first needle. And remember that this is IOL is made, the haptics are made of PMMAs, not of PDF. And I tried, as Brian mentioned before, try to load this leading haptic while the IOL as if inside the cartridge of the injector, but I failed because, as you can see, the control, I'm trying to control the lens with the right hand, and to feed the leading haptic, it was quite difficult to control the situation here. So I'm stuck midway, either to enlarge the wound and explant this lens outside the eye and try to fix the other type of lens by glued IOL or whatever, or I have to find a solution. So I decided at that time to keep the lens inside the eye and shift the technique from the Yamane technique, which is my preference for such cases, but I have to shift now to the glued IOL technique. And you can imagine, now I'm doing the glued IOL technique with one hand, with my non-dominant hand. This is my left hand. I'm creating the scleral flap while holding the haptic of the lens, the trailing haptic of the lens outside the eye with my right dominant hand. I'm trying to work as fast as possible at that time. Even I didn't do any cautery for the bleeding, just do the sclerotomy, the 1.5 millimeter from the limbus, and try to catch this lens before it fell down into the posterior segment of the eye. Now with the micro forceps, I could externalize the leading haptic and left the trailing haptic outside the eye. At this time, probably I can take my breath. I could take my breath and to secure the lens from falling down into the posterior segment. And now starting again, after securing the lens, and start now to do the sclerotomy and the scleral flap from the other side. And now I'm working with my both hands as the usual surgeon. This is the scleral flap, and then securing the lens, introducing the trailing haptic inside the eye. And this is non-assistance technique published by Priya Narang, modified technique. I'm just putting the microforceps underneath the trailing haptic to support it, and do the handshake technique to catch the tip of the trailing haptic outside to externalize it outside the eye. Now both haptics are externalized outside the eye, and I had a sigh at that time that my job is almost finished and I could secure the lens from falling down in the posterior segment. So one advantage here with the glued IOL technique, that we can control the centration, which is critical in this case because we don't have enough iris tissue. We can control the centration because centration is much more controllable with the glued IOL technique, as mentioned previously, few minutes before, compared to the Yamane technique. So my conclusion here is sometimes glued IOL is better if there is no iris support in such cases, or the centration is critical, and the technique of intrascleral haptic fixation should be carefully taken and individualized according to each case. Thank you very much.
That was really a fantastic technique, and doing it with your non-dominant hand is really fantastic. How you are, and that shows the versatility of the glued IOL. You can shift from Yamane to glued IOL, and that's the advantage of glued IOL. And
yes, I do believe that surgeons should master both techniques.
Yes, sir. Any questions from the panelists on this particular topic before we go into the next speaker? Next speaker is not available, so we'll put this video.
This is the glued IOL is the basic skill. It's like divide and conquer in cataract surgery, and Yamane is the step up. I strongly believe you should have both, and so that you can switch on the you need, just like was shown. As excellent technique, excellent presentation. So thank you for showing that.
I agree. So important to have seen that video. Thank you, Ahmed, for sharing that, because we all show videos of everything going well, but that's an example of what can go wrong. Very important to learn both techniques. I think Brian Kim's trailing haptic first technique would help if there's no assistant available. I'm lucky that I usually have a resident or fellow working with me, but when you don't, I think that can be really useful. But thanks again for showing that. Very important video.
Thank you.
Eric, you have anything to say, sir? Yeah. Okay. Then we'll go on to the next speaker. The next speaker is not available, Dr. Sadir Unish, but his video will be putting. Kumar Guru, can you just put on Sadir Unish? He's going to show us.
Yes, sir. The presentation will be on. Yes.
Intrascleral haptic fixation. Can I have the video on, please? Yes. Can you play the video? Is there any voice there? Is there any sound? Kumar?
Mohan, move to the next speaker, Mohan.
Yeah, we'll go on to the last speaker. And yes, sir.
No.
Yes, I'm right here.
Yes, Kanabrava. Yeah,
my friend.
He's
I'm right.
The new sensation of the millennium, I would say, Kanabrava.
Good evening, colleagues in the Indian subcontinent and around the world. My charge tonight is to discuss intrascleral haptic fixation with corneal surgery and single-pass fourth-row pupilloplasty. This is Sudhir Hanish from the Cornea Service at Wills Eye Hospital in Philadelphia. Single-pass fourth-row pupilloplasty is a pupil reconstruction technique that simplifies the performance of pupilloplasty and iris repair. This is a patient referred to us after complicated cataract surgery with marked corneal edema, surgical aphakia with no zonular support, and significant iris damage. We mark the limbus to prepare for scleral fixation. The epithelium is removed to allow better visualization. 2 23-gauge transconjunctival sclerotomies are created. And then after performing the generous anterior vitrectomy, the lens is prepared to be sclerally fixated. This is the CT Lucia 602 lens and a thin-walled wide-bore 30-gauge needle from TSK in Japan. You see me feeding the haptics into the lumen of the needle using the technique described by Shin Yamane. The haptics are exteriorized on both ends, 2 millimeters posterior to the limbus. I like to trim them, and then cautery is used to create a flange at the end of each haptic before feeding it back through the conjunctiva into the scleral tunnel. Once this is completed, we are ready to do the iris repair. A 10-0 polypropylene suture on a straight needle is passed into the anterior chamber to engage both pupillary edges and then fed into a 27-gauge needle. It is looped out of 1 paracentesis, and then the leading edge of the polypropylene suture is fed 4 times into the created loop, thus the name fourth row pupilloplasty. The 2 suture ends are then pulled, and without any additional passes, the procedure is completed. If there's need for more iris repair, a 2nd or 3rd suture can be placed. Here you see me doing a 3rd suture in the iris, again, exteriorizing a loop from the trailing aspect of the polypropylene suture and feeding the leading aspect of the 10-0 polypropylene 4 times into this loop. Once that is completed, the 2 suture ends are pulled and the iris comes together nicely. Obviously here there has been significant tissue damage from the previous procedure. I will now proceed to score the endothelium and Descemet's membrane with a reverse Sinskey hook and start stripping Descemet's membrane. This is a stripper completing the stripping. And then in some of these instances, after the tissue is removed, we like to use the vitrectomy cutter both to remove the viscoelastic and to clean up any fragments of Descemet's on the posterior surface of the host cornea, marking the pre-cut donor tissue, placing it on a Busing glide, and gently preparing it for insertion into the eye, using an MST forceps. The tissue is pulled into the eye, and a gas bubble inserted to tamponade the tissue against the cornea. Postoperatively, the cornea is crystal clear, the pupil is of relatively regular shape, and a well-positioned transsclerally fixated posterior chamber implant is in good position. The single pass 4-throw pupilloplasty technique minimizes iris manipulation and allows for stability of the anterior chamber when combined with other procedures, such as intrascleral haptic fixation, posterior chamber IOL implantation, and endothelial keratoplasty. Thank you very much for your attention. I have two questions from the panel. The first is, how does this technique of pupil repair compare to other pupilloplasty techniques? Well, there are two ways it offers an advantage. First, in its simplicity, and secondly, with minimizing anterior chamber manipulations. So this was really a single pass with 4 throws, and we do not have to put a second knot or a third knot in the iris. The second question from the audience is, can this technique be combined with other endothelial keratoplasty procedures, such as PDEC or DMAC? Of course, if you're comfortable with these endothelial replacement techniques in a setting of a unicameral eye, absolutely, it can be combined. And can one use this technique with other scleral fixation PCIOL techniques, such as the glued IOL? And the answer is, of course, you can. Thank you very much for your attention.
Thank you very much, Sadir, for the wonderful, wonderful video. I think you've shown the SFT as a very good technique, as you all know. We'll come back to the panel, and I would like to introduce Sergio Canabrava. He's a new kid on the block and a new sensation, I would say, because he has made some new vistas as far as the scleral fixation with his flange technique concerned, the Canabrava technique is concerned. He's from Brazil. Over to you, Canabrava.
Hello, my great friend, Mohan. How are you, my friend?
Fine, fine.
First of all, thanks, Ashwin, Amar, for this great meeting. It's amazing meeting. Let me share here. Can you see my?
Yes, yes, Sergio. I'm able to see it.
Okay. Today we'll talk about the 4-flanged Canabrava technique. Here my disclosure about this talk. I like to say every time, when did it all begin? When in 2016, when I see the flange published by Dr. Yamane. And then I had the idea to use a simple haptic from an IOL to do the first double flanged technique. And then Dr. Baker is here. It was my first prize that I received from the Dr. Baker hands about this double flanged haptic. Then in late of 2017, I have the idea to use a simple polypropylene suture and create an enlarged suture. And then was create the first double flanged. And here, 2018, using a patient with Marfans syndrome that I published in IIRSI with this polypropylene adjustable suture. Then late of 2018, I have the idea to use 2 double flanged sutures to create the 4-flanged. Here, the first surgery that I did in a 4-flanged, a traditional scleral fixation like Lewis and Malbran, that I use a 5-0 propylene suture, and I insert it in eyelet of the single-piece PMMA IOL, and repeat the procedure in the other side, and I insert the single-piece PMMA IOL inside the eye. Observe how it's important to insert it in the sulcus to avoid tilt, like in Lewis technique, and then you have adjustable suture outside the eye. And then it's important to cut it about 2 millimeters from the basis, because you have it tensile, and then you insert it inside the scleral tunnel as Dr. Yamane told, to avoid conjunctival erosion. Then after this, main surgeon, here the final results, main surgeon asked me, Sergio, is possible to do it in foldable IOL? I did a lot of tests with horizontal, vertical axis, different IOLs, punch IOLs, but when you piecing the IOL, it's not stable. Then I keep my research, and then the idea to use 4 eyelets IOL like acros. And then the first 4 flange technique using a acros IOL with a 29 gauge needle and a 6-0 pro-lens suture. Then here I use a pro-lens suture, and I insert it in the 4 eyelets of the IOL, and then I back with the 3rd point. In this technique is stable because you use 4 points fixation. And then I insert the IOL in the eye with a 3.4 millimeter incision. And then only the IOL inside the eye, I pass the 4 point fixation. Okay, it's important after to have the 4 points in the eye, you need to do the first and the second flange in the bottom because you can adjust about the upper suture. And when the IOL in the right position, you do the 3rd and the 4th point fixation insert in the eye. But why did you double flange polypropylene change the game? I believe because the polypropylene costs $3. It's 100 more resistant than 10-0 polypropylene. And the surgery is performed outside the eye. Okay, since 2019, many surgeons publish different techniques using my double flanged, and including Dr. Mackey's a great technique that Dr. Mackey published. Here, for example, Dr. Kashikian uses the double flanged to fixate iris fixation, and the more strange for me, veterinarian doctors use the double flange to perform it in dogs, because they told me, Sergio, the dogs, there are a lot of blood in sclera, and it's impossible to do suture. Your suture was amazing for us because you don't have to do a scleral flaps, and dogs has a lot of subluxated cataract. And it's possible to do it with a lot of IOLs which are in the world. And till now, after 6 months research, I have these numbers. And of course, longer follow-ups are necessary to verify safety and efficacy. Okay, thank you for the invitation. I'm happy to stay here with these topics, guys, in the world.
Wonderful, wonderful. What a lovely technique.
Very nice.
Yes, sir. Eric, sir.
Yeah, just a great session, Mohan, and thank you for organizing this session and all your hard work. So many good techniques and so many ways of rehabilitating patients. I think we saw some wonderful techniques here. I think we're a little behind in the meeting, so Mohan, I'd ask you to maybe just close with some final comments, and we'll move on to the next session.
Absolutely, sir. I think it's been a very stimulating session, and we have opened up new vistas as far as the scleral fixation is concerned. We have covered the 360-degree coverage as far as the intrascleral haptic fixation, glued IOL, Yamane technique. I thank all the speakers and all the panelists for their expert comments, and also the speakers for the wonderful presentations. And we go on to the next session. Thank you very
much, Mohan and Eric, and the entire team who have done the second symposia. Fantastic it is. I request you all to just unmute and switch off the video, but please stay into Hall A because there'll be a lovely session next, and then is the film festival. Mahipal, we have a great session next one on, and we have 2 great people who are going to moderate that session, and that is none other than perhaps one of the doyens of ophthalmology who really took India to the global map, and that's none other than Abhay Vasavda. And the second person is Tom Oetting, who's such a dear friend and such a great teacher. And Tom, you know, your Facebook videos which you put up are something which is cherished by everyone globally. Mahipal, over to you.
Thank you very much, Amar, and thank you very much, Mohan and Eric, for and all the speakers and the panelists for the excellent session. Let's go on to the next session, which is none other than the session on Phaco nightmares. And these are nightmares which great surgeons will come out of and give us tips as to how to deal with these difficult situations. So without much ado, I think I'll pass it on to the great moderators and the panelists, the moderators, Dr. Otting and Abhay Vasavada, and we have Bonnie, we have Kendall, and we have Bruno as the panelists. So over to you, Abhay, and to Dr. Tom Otting for the session on Phaco.
So before we go ahead, we'll go for the sponsor video and then go ahead for the third session, sir.
Before we start, Abhay, just a minute, there's a small video by the sponsor. Yeah, over to the admin, please.
Yes, Abhay.
Yeah.
Yeah, thank you so very much. I enjoyed the presentation very much and hope we can repeat that. On behalf of Thomas Utting, I welcome you all, and we have a great faculty on the speakers and panelists as well. Without any waste of time, I would ask Robert Weinstock to start his presentation.
Okay, hope everybody can see me okay, and we'll get going here. Let's see if I can share the screen. If you can see the screen. First, I want to say thank you to Amar for inviting me to do this and for being such an amazing mentor to me over my career. I'd like to share some challenging cases, a couple here, very dense cataracts, and I think all of us encounter these in our practice, and especially these cases in a previous vitrectomized eye where you have these very dense rubbery cataracts and this dense posterior plate. And right here, where it's so rubbery and you're trying to crack it, is the real trouble point, right there. Typically, that little pop right there is what breaks the posterior capsule. And when you're trying to remove these dense rubbery cataracts and remove them from the eye and the capsule's open, undoubtedly, some of them fall into the back. So here you can see a bimanual technique, which I use for all my cases, and I'm doing anterior vitrectomy on the eye, completely cleaning up the anterior segment. But what I think is a little progressive, but yet viable, is to put a lens on the eye and see what's going on in the back and go a little bit deeper with your vitrector. Now, we're going through an anterior wound. We don't have a scleral wound, but with a bimanual technique, just by putting a simple retinal lens on the eye, you have an excellent view of some of these smaller particles, which are easily removed with a vitrector. And this eye has already had a previous vitrectomy. So, you know, if anybody's gonna be trying this and putting a lens on the eye and doing a little bit deeper vitrectomy to remove these pieces, it's always good to start in a previous vitrectomized eye, because you know the vitreous is always already gone, and you know you're a lot safer to move a little bit deeper into the eye to remove those little small pieces that may be left behind and avoid a second surgery for the patient. So all of us know how to do anterior vitrectomies, and I think it just, for some reason, there's an obstacle of thinking that you can't go a little bit deeper into the vitreous. As long as you have good visualization, it's very easy to do. Now, on some more challenging cases, it always helps to have a sclerotomy port. But here's a very dense cataract, and you can see right away going in the eye, the entire nucleus just drops into the posterior segment as soon as we get inside the eye. So we have this irrigating chopper ring, which acts like an AC maintainer. And through the vitrectomy point, we can go in with a vitrector and completely vitrectomize over the nucleus of the eye. Make sure all the vitreous is cleared out of the way. Now, sometimes the actual nucleus will come to the vitrectomy tip and you can pull it off, but these vitrectors that go through the sclerotomies, these 25 gauge vitrectors, are very small. They're very hard to get a giant nucleus up with the small port. It tends to just fall back down. So what can you do once all the vitreous is gone? With a bimanual technique, you can go back in with your Phaco needle, visualize the nucleus, that's right in front of you. Make sure you have great visualization. You've cleared out the vitreous. And with just a little vacuum, it just comes right to the tip. Comes right on up. You can grab it, pull it up into your segment, remove the lens from the eye, focus up very easily, and pull this giant rock into the anterior chamber. Now, fortunately, we have a small pupil here that's acting like a scaffold, but this lens is so rock hard, and I could already see how dense it was. I made a decision to abandon phacoemulsification and use another technology that has come to market, which can be used in certain situations like this, even though it's not in the capsular bag, to split this rock hard rubbery cataract in half with the MyLoop. Very nice tool for some of these really challenging cases. So once we do this, we don't have to open up the eye all the way like we normally would for an extra cap, because we can now cut this nucleus into smaller pieces and have a smaller wound. Once the nucleus is out, finish up the core vitrectomy. Now, there's always going to be little pieces left behind, but most importantly, we have nice clear visual axis here. And in this patient, it was an elderly patient with a very healthy cornea, the quickest and most efficient thing to do. And I think that in today's world of all the fancy techniques that we see, we forget that the AC-IOL is very viable. So here I'm going back under the IOL, through the iris, through the vitrectomy, and cleaning up with the retractor just any small fragments of cortex or any little pieces of nucleus that might be there. The sclerotomy point is removed and the case is complete. So I want to thank Amar for helping me learn how to do this technique, and many surgeons around the globe that push the boundaries of their skill set a little bit. And for surgeons that want to clean up their messes that they create and avoid second surgeries for the patient and can navigate these waters and feel comfortable, I think it's something that cataract surgeons around the world can use as their skill set, especially if they don't have access to retina immediately. Thank you.
Thank you, Bob. This was a very nice case, really nightmare case, and you did a great job. Ultimately, it's the safety of the eye and whatever is the best in our hands. We need to do that, and you exemplified so well. Thank you. Now, Bonnie Anderson is with us, and Bonnie, do you have any comments or anybody else?
Sure, absolutely. First of all, I think I probably speak for everyone that gives me tachycardia and heartburn just to watch those terrible cases, because we all have them, and it's amazing how much my even heart rate and blood pressure goes up. It's not even part of the surgery, but beautifully done. And I just want to highlight, I think that it's really important that any of these procedures, if you're trained and you're skilled and you know how to do them, I think it's very relevant to do that. If you don't feel comfortable doing a vitrectomy, I think there's no shame in closing up, cleaning it up, and saying, okay, refer to a retina colleague. But like Rob showed, and Abe, I know you're an excellent vitrectomy surgeon as well. So if you know what you're doing, I think it's perfectly reasonable. So thank you for sharing that beautiful case.
Thank you. Thomas?
Yes, the only thing comment I had on that, I just wanted to point out that the Academy just came out with a technology assessment paper this month, which once again looked at all the various techniques for placement of an IOL without capsular support. And once again, the assessment was that they're all roughly equal, including the anterior chamber inocular lens as Rob used in that case. And even though we're excited about the various new techniques, it was surprising that once again, with meta-analysis, there doesn't appear to be an advantage of one over the other, which leads me at least to think that we should use the procedure that we're most comfortable with. And so I think Rob's case points that out, that you already have a big incision, place an anterior chamber inocular lens seems to make good sense, particularly given this data from this recent meta-analysis.
Okay, I think we can move on to the next case.
So I think yours case is next, Abe.
Yeah, okay. Well, this is my financial disclosure, and in India we use silicone oil much more than in USA, and it universally produces a fibrotic plaque of different morphology typically it's a diffuse fibrotic plaque with traction on the capsule and retina on the zonules, and it's impossible to yard them. I'm taking this case with a very mild form of plaque we discovered after the cortex was removed. We decided to put the 3-piece IOL, a very low-powered -1 IOL, into the bag, and then remove the silicone oil. And that's where my colleague, retinal colleague, comes and takes over. And he removes the silicone oil in a very predictable fashion. And he does a very complete, thorough job. And once that is done, I do the posterior capsulectomy using the highest cut rates, which is 5,000 here. And it's a relatively very simple procedure. And it went very well. We removed the trocar, and we were very happy that we could achieve that. But once we looked into the microscope, we realized that the capsulectomy extended to the periphery, and that will not a good thing. It will unstable the IOL. So we decided to put the IOL in front of the anticapsule, and that's where we made a mistake. Instead of going underneath the IOL to lift it up, the surgeon goes and tilts it and makes sure that it's vertically tilted, which is the last thing we wanted. And therefore, with our dismay, the IOL started sinking and disappeared very rapidly. The retinal colleague, once again, look at the teti-retina. He brings the IOL up into the anterior chamber, and once again, I'm fixing the left hand with the left hand IOL and trying to rotate, which is a mistake. And that's what caused the haptic breakage. And it's so difficult to retrieve if it sinks again in the posterior segment. Luckily, I could put my hands on it, and then the haptic was taken out. And then we had a question, should we replace this with some other IOL fixation techniques? This being a -1 IOL, we thought of leaving it a phakia because the residual refractive error won't be an issue with this patient. So in this case, we left him a phakic. Once we had the other time, a month later, a case of a very fibrotic diffuse plaque, we did the same procedure of siliconal removal, but never placed the IOL at that time in the bag. We decided to treat the capsule first before we implant the IOL. And for me, posterior capsulorhexis is a fairly good option to the capsulectomy. Initialization of the puncture is very difficult in this fibrotic thing, and we need to take our time lifting the capsule toward the center, but also towards the cornea as we progress, and use the different incisions for better ergonomics and achieve finally a desired smallest size of clearance in the central axis. And then a single piece hydrophobic IOL was placed. Notice that the irrigation is still maintaining the chamber and preventing the forward bulge and then prolapse of the anterior lens forward while I'm hydrating it. And this is how it looked post-operatively. So what lessons we learned is that it is very difficult to yard these fibrotic capsules, and surgery remains a very good option. Capsulectomy versus PCCC. Having learned the hard way, I prefer PCCC if I can do it. And I prefer a PCCC with the surrounding support of the fibrotic capsule and diffuse plaque formation so that it never extends to the periphery as you saw it. And then remove the silicone oil prior to PCCC, of course, and then implant later on at the very end. So this is what I learned, and this has been our standard practice now in cases with the silicone plaque, and we are recommending it if one can achieve a PCCC in these cases. So thank you so very much.
Well, thank you for that case, but it's very interesting, and for sharing that time when it must have been awful scary when that haptic fell. Kendall, I was wondering, thank you for being on the panel, Kendall. I was wondering if you had any comments on maybe on posterior capsulotomy, which is interesting, or any more comments on Abe's interesting case.
Yeah, thanks so much, Tom and Abe, for including me in the panel. That was a great case and very challenging and an important discussion to have. You know, we really have to determine whether or not we're going to take out the oil ahead of time, have the retinal specialist take it out beforehand and have it as a staged approach, versus do all of this at the same time, versus leave the silicone oil in some cases, of course, and that can affect the IOL calculations as well. But the posterior capsulotomy there can be tricky. I've had some success yagging those plaques, but you illustrated perfectly some of the challenges, how those plaques can be so fibrotic. It can really have a tendency to tear out toward the periphery. And I think just like an anterior capsulotomy, the Little's maneuver and pulling back in, or using the other instruments that you did so nicely there, Ave, with the scissors or whatever else we need to do to keep that from traveling out, those are all great techniques. But sometimes they are yaggable. I mean, you kind of have to, look at the degree of fibrosis and all there to gauge that. But those are great points. And sometimes, if you're doing removing the silicone oil at the same time, you can get some retention of the silicone oil. So if it's going to be removed, a lot of times I'll like the retinal specialist to do it in advance of the surgery to make sure that they can do the air fluid exchange and all that to make sure they remove all the silicone oil, and then do the cataract surgery can make it a little simpler.
I think you brought out a very important point that the retinal colleagues needs to be involved in, and if possible, we can have that removed earlier surgery, which will make our life easy for the cataract surgeons. But the point is that at the present time, we need to co-manage with our retinal colleagues more often than we used to do in good old days. So I think that we need an ego issue, and we need to work together. So thank you so very much. I think the next speaker is Thomas Utting himself, and he's going to speak on dead bag. Thomas.
Thank you. Here's a case I wanted to show, and I wanted to also get the opinion of people and see how often they've encountered this before. It refers to this thing known as dead bag, and I'll talk about that a little bit as this goes on. But here's the case. So this was a really odd situation. This woman was 20/30, and you can see that the haptic and the bag were in the anterior chamber on one side, and on the other side, it was in the normal position. And so I decided I would try this technique that was showed in the last session using the Prolene suture and that Canabrava has championed, and we're going to use 5-0 Prolene, and we're going to place it just anterior and just come through the anterior chamber wherever we can. And I've had some luck with this procedure, but as this is called the nightmare section, you can imagine I did not have luck on this case. So we're going to pull this Prolene suture through, place it through the central eyelet of a capsular tension segment, place this in the eye. And here I'm sort of maybe naively or hopefully going to place this into this bag, which is shockingly without fibrosis, shockingly clear for a patient that's 10 years out of surgery. And this is an example of this really strange syndrome, this dead bag, where there's just nothing to the capsule. It's surprisingly thin. And in this case, the zonules are much weaker than I expected. And this is never going to work. This is a disaster. Here I have, look at this, where I have two hands because the resident's helping me cut this lens in half so it doesn't fall. And we're going to pull this lens out. And now we're going to regroup. Doing the anterior vitrectomy here. Now I'm thinking, what am I going to do now? I don't have CT Lucia lenses or Technis lenses in the OR for a Yamane technique. And I'm going back to my tried and true technique, which I learned from Dr. Agarwal, who's one of my heroes in ophthalmology. And he helped me so much with this technique, which really is handy. And we happen to have MA50s in the OR. So that's what it was my go-to technique when I'm in trouble. And so here I'm going to place the sclerostomy, grab the haptic. Everything's going well so far. I'm not too worried about this. I've done this a bunch. Pulling out this haptic. Already celebrating, but look, we lost control of that one haptic. And now we've just got one haptic out. We're just kind of going back and forth. One haptic out on one side, one haptic out on the other, but we haven't solved our problem because we got to get both haptics out. So we're going to go back to the drawing board and re-grab and do a handshake on the other side. This time we're more careful to make sure we've got a good grip on the other haptic. And so we ended up doing the glue technique, which we've seen in a lot of videos in the last session. It's a great technique in my hands, at least. You don't have to, we have the lenses available for it at any time. It's a very comfortable situation no matter what's going on. The eye doesn't have to be perfect for this to happen. And so it's very useful. So the dead bag is is kind of interesting to me. It's rarely discussed. There's very little literature on it. It's basically, I think, when there's no fibrosis, even after years and years, there's probably no migrating epithelial cells at all. Maybe it's from too careful cleanup at the time of surgery. Maybe there's something else going on. There's often weak zonules associated with it, and often very thin distended capsule, as I'm showing on the right here, where this is a lens that's 10 years out after surgery, and the bag was so big and distended that the lens was just loose in the bag. And so it's kind of an unusual situation. So anyway, that's my case. I just wanted to stop just for a second and just say thanks again to Dr. Agarwal for all of his mentoring over the years, which allowed me to get out of trouble in that nightmare case that I showed you a second ago. So I wonder if Bruno has any comments on this case, or if any of the panelists have ever seen this dead bag syndrome before.
Great case, Tom. Thanks for inviting me, having me here. I'd like to say hello to all my Indian friends and friends all over the world. Well, Tom, a great case. I had a very similar case last month here in a very old patient. He was 94 years old, and he had this partially subluxated IOL after falling in the stairs. As I got a very old patient, I didn't want to get a lot of bleeding and things like that. What I did a double hashtag technique. I put a Prolene suture below the IOL, and then I sandwich it with another double Prolene hashtag above the IOL. So I get all the bag complex in place, and it was like a 20-minute surgery. It wasn't a very bleeding, and the patient is doing very well. But I see some cases of it. It resembles like some pseudo-exfoliation cases. There are a lot of things that can happen to the eye, but thankfully nowadays we have many different techniques for IOL fixation, and we have to figure out and choose whatever is better for the patient at that time.
Anybody else? Any comments on this?
Okay. I'd like to make a comment. Yeah. We have a series of patients with the dead bag syndrome, and every time I try and put a segment in, or I think I can do a CTR and everything's going to go great, I have the same experience, Tom. So you're not alone. And so, you know, I know that Dean and Steve Safran and other people have cases like this, and I've sent a few to Liliana Werner, and we should try to understand the pathophysiology a little bit more.
Thank you. I think, Nicole, you are the next speaker now, and I must let the people know that every time I've heard you or discussed with you, I've learned a lot. You're a brilliant surgeon, Nicole, and please go ahead with your presentation.
Thank you so much. I want to thank Amar and Ashvin for inviting me to be here today, and to be here with Abe and Tom Oding and all the panelists. It's really unbelievable. So thank you. So I want to share a case on what I call a million cut RK and Marfans. Real easy, right? So this patient's 56 years old. He's a dentist. He wants perfect surgery and to be rehabilitated in 2 weeks. What you see is that I marked the RK incision so that I don't intersect. I filled with viscoelastic right over the area that we had the zonulopathy, because I want to block it when I stain so that I don't create a problem with a red reflex. When you initiate your capsulorhexis in these cases, you want to make sure you use the zonules that are good. And actually in this case, I'm going the wrong way. So I'm not propagating in the direction of the weak zonules, and I got lucky. But in general, you want to go the other way so that you can use the good zonules. I made a scleral tunnel because I don't want to intersect with my RK incisions. And then when I'm finishing this capsulorhexis that I didn't center on the center of the eye, I centered it on the center of the lens, I want to finish on the outside of my capsulorhexis. You can see there's a little bit of iris prolapse here, so we're going to deal with that later. Here I'm going to put viscoelastic under the capsule, and I'm going to use the Chang modification of the MST capsulotomy retractors. And you don't want to pull too tight. They're just there to reinforce the equator. Now I'm making a little paracentesis under my incision so that I can get control of this iris before it becomes a problem. So it's like watching for the signs, because if I keep going in and out, I'm going to ruin that iris. Here, now that we have our artificial zonules in with our capsular retractors, we're going to go ahead and try to crack. And when you have loose zonules, you're not going to be able to crack. So I use viscoelastic to I had a little crack, so I just propagated it with some OVD. And then here, we're just going to take up one heminucleus and keep our flow rate low, because these zonules are very weak and things want to jump into the phaco tip. And then we're going to get the other side here, and we're pulling towards the center, staying in the center. And as we take that last piece, you want to make sure that you're filling with viscoelastics, the bag doesn't jump into the phaco tip. Now, one of the things I just did was that I visco dissected under the capsule to release the cortex so I could get it out easily. And then we're going to use a bimanual technique with the CTR. CTR placement, you can see here, it starts to straighten out. I was a little nervous. It's not benign. So you have to make sure that you fill the bag really tight before you put the CTR in. Then when you're taking out these MST hooks here, you just make them parallel to the limbus and you can get them out pretty easily. Now I made a groove and I'm going in with 23 gauge equivalent MVR blade. It's an Alcon 1 millimeter blade. I'm 2 millimeters posterior to the limbus and I'm 2 millimeters apart. I like to use an Ahmed segment and I'll do this in a needleless recovery fashion using Gore-Tex off-label. And we're gonna go in, and you can use the Canabrava technique as well. And we're gonna go in and put one side in first, then put the entire Ahmed segment in, then retrieve the other side. And this way you're not yanking on the capsule as you're bringing it into the eye. Now we're gonna tie a slip knot here. So 1, 1, 1, 1. Before we do that, let's polish the capsule, because if this capsule gets very fibrotic, it's gonna pull over time. So we're gonna tie here in a 1, 1, 1 fashion. The reason why I like Gore-Tex is because I can titrate it better. And you see how I tie and then I pull from a paracentesis. Then we're gonna go ahead and cut the knots. You have to have the knots and the ends buried. And a lot of times you don't wanna tie it off before you put the lens in. You wanna keep it loose, because I have had times where the capsule broke as I was putting the lens in, and that's very sad. And we're gonna use some preservative-free triamcinolone. So this is a big pearl. You have to make sure that the pupil comes down and that you have no vitreous prolapse. And then make sure that everything is normotensive at the end of the case. So I just wanted to share this case with you. This patient, had great rehabilitation. We got lucky in this case, and it's just a pleasure to share all these pearls with you today.
Wonderful, Nicole, wonderful. As I'm not wrong, I always pick up some nice points, and you showed it how to persevere with this sort of a problem. Bonnie, any comments on this?
Sure, Nicole, a gorgeous case and so well managed. I wish we had an hour just to talk about that case. There were so many things that you did beautifully that we don't have enough time to highlight. But one thing I just wanted to highlight was, how controlled Nicole just managed that case. So a lot of it has to do with pre-planning, knowing what to do ahead of time. So you really have to think about these cases ahead of time. The second thing I want to really highlight is she did not rotate that lens in the bag again and again and again, regardless of whatever technique you normally use to remove a cataract. In a situation like this with weak zonules, you notice that she didn't divide and conquer. She didn't chop and rotate and rotate. She literally removed the pieces where they were. And I think that really salvaged the remaining zonules and made it a gorgeous case. So again, thank you for all your education. And thank you, Abe, Tom, and Amar, and everyone else on the panel. It's a pleasure to join the screen with you.
Thank you. Well, I think if we don't have any other comments, we can move on with the time we have.
Yeah, I think our next case is David Chang, who is all of us a mentor to all of us, certainly to me, and he must be very early for you, David. You must be out in California, and we appreciate you getting up early to join the rest of the world and tell us about a case that he calls the Titanic, which must be a disaster. So let's hear about it.
Right. So I think the AV team is going to show my video. You ready? If not, great. So the pearl is to find a lifeboat, and we can advance the slide and start the video. So this is just a very dense lens. I've stained it. I've done my capsulotomy, and so we'll do some vertical chop after some sculpting. And we reach this point, there's a plaque in the posterior capsule. I'm trying to get this piece under the iris, and all of a sudden I see this movement of the posterior capsular plaque, and I've got vitreous. Now, what's under the iris is difficult to see, but it looks like it's going to be a fairly large piece. And you have to have this mental picture in your mind that keeps you from going after it, because if you chase it with the phaco tip, the downward direction of the infusion is just going to wash everything posteriorly. So it's rather large, and I have to say, well, there's got to be vitreous in there. So my strategy is to fill the anterior chamber with a dispersive viscoelastic so that I can support that piece. I do use the iris here, but I always want to support the lens material with dispersive so that when I do the vitrectomy and remove the support of the vitreous, things don't just sink posteriorly. So here I'm now going in with a pars plana sclerotomy, and I'm going to stay behind the iris so that I don't remove the dispersive viscoelastic that is supporting all the lens material. So I have a limbal infusion, but I keep my vitrector sort of pointed posteriorly. I'm trying to transect any bands of vitreous that are sort of moved into the anterior chamber. So now I'm trying to see, well, I can see a little bit of a capsulorhexis there. I should have the capsulotomy intact. So I'm going to try this idea of using the 3-piece IOL as a, as a scaffold, as reported by Amar. I'm not really sure what's going on my left-hand side, so I'm a little worried about placing that haptic since I can't see the rhexis edge. So I'll leave that haptic trailing. The pupil is small enough that it's also helping me to support things. And I'm just going to now try to remove, there's a little epinucleus that I'm aspirating there, and then I'll go after that final big chunk of brunescent nucleus. So I still have to chop it. And what's happening now is the IOL is sort of migrating a little bit to the right, unfortunately. So I have to keep my phaco to the right, and the IOL is both a shield. It's keeping me from aspirating vitreous, and obviously it's the floor that's trying to, it looks like the video is locked up there. You're controlling it, I believe. So if you can you just advance the video just a little bit on your end? I gave the video to the people in India. Can you just refresh the video? So one of the questions is, how do you keep this IOL stable? Kumar? It looks like he's working on it. Oh, thank you. All right. And then the last piece is there. So now finally the nucleus is out. I can breathe a little easier, and it's time to do a little inventory of what else is left. Now it's time to enlarge the pupil. Again, I kept it smaller earlier because the iris was part of my scaffold. And now I can see that there's mainly cortex. This is a vitrector here through the limbus to get some of the strands here. I certainly could use triamcinolone. The view is pretty good. Now I'm going through the pars plana, cleaning up again, and I can actually see a complete CCC. So this is then easy. I can just drop this in the sulcus, and the rhexis is still the same size. So I'll just capture the optic with the rhexis, and then I'll bring the pupil down. I'll close the sclerotomy with an atovicral, and luckily did not need to do anything further. There was a little cortex posteriorly, but no nucleus. and the patient did fine. So this technique that Amar has popularized using the IOL as your scaffold, I think worked really well here. Thank you.
Wow, that was a great case. Thanks for sharing it, David. Kendall, do you have any comments on this, or the other panelists?
Sure. Well, that was a great case, certainly very stressful, David, but thank you for sharing. Again, as you mentioned, Amar Agarwal's IOL scaffold technique and using that in conjunction with the iris to support that material was really key. You also mentioned the use of dispersive viscoelastic, both behind and to protect the cornea endothelium as well. So using 5 or 6 tubes of viscoelastic could potentially be very helpful during a case like that, but again, below as well as cushioning the endothelium. So those were really great points. It's a tough case. I like the optic capture technique because then you know that you're not going to have continued vitreous coming into the anterior chamber. The use of preservative-free triamcinolone could also be helpful there. I like to use the Myocon in every case like this, and I always put a 10-0 nylon in the wound and make sure, just to make 100% sure that there might not be a little piece of residual vitreous around. So I think it's good to be secure with all that. But that was a tough case, and you handled it really nicely. Lots of different techniques there that were helpful.
You showed it very well, a great skill. But for those who are not very familiar with pars plana vitrectomy or scaffold, just do a limited entry vitrectomy and say bye-bye to this sinking fragment and send it to retinal surgeons, because as handle both mentioned it. It's very important that we understand what is good and safe for the patient. But David, wonderful. Thank you.
Yeah, I think the single biggest point was just don't chase that piece with the Phaco tip. It's so tempting, and that's where you get into trouble.
Thank you. I think we move on to the very important topic here, small pupil, and Boris Malugin has been synonymous with the small pupil. Boris?
Yes, I'm happy to share with you my technique. Hopefully you can see my screen now. Okay.
Yes.
Yeah, that's it. So I will be discussing the small pupil management, and I thank very much Agarwal for inviting me to be a part of this exciting panel. So there is a combination of congenital anomalies and maldevelopments and surgical manipulations that can bring the pupil down in pediatric cataract cases. Even with mydriatic protocols, pupil may remain small during the procedure. And obviously, iris hooks is one of the options to be considered. Although we know that in small eyes, there is a poor exposure due to the narrow palpebral fissure may give the surgeon some troubles in dealing with these cases. So there are several evidences in the literature that pupil expansion rings are easier to use, require less operating time, and provide stable pupil during the surgery. And there is one publication on the using of the pupil expansion ring in pediatric cataract surgery. So these are anecdotal, mostly this is an anecdotal report. So here is my technique. As you can see here, this is the patient, 2 years old with cataract. And I will be using the second generation of the pupil expansion device, which is now inserted into the anterior chamber. I use the smaller one, 6 1/4, because the anterior segment of the eye is having smaller dimension as opposed to the adult eye. So I will need to manipulate through the paracentesis in order to catch the pupillary margin, as shown here. The eye is quite small and the palpebral fissure is not so big, and anterior segment is also relatively small. So you need some additional extra manipulations in that case. However, as soon as the pupil expands, there are no big difficulties from that point. I do like to initiate my capsulorhexis with a sharp bent needle in these cases, and then follow with the micro capsulorhexis forceps. This is the Cybele Rexis ruler that helped me not only to create very nice anterior capsulotomy, but also to measure it. As we know that in pediatric cases, there is expansion of the rexis that happens due to elastic properties of the capsule and elastic properties of the zonial. So I usually aim for my capsulotomy not to be more than 3.5 millimeters in diameter. Evacuation of the cortical material is not a big deal in these cases. As you can see, it is being done with bimanual irrigation aspiration handpieces, and I will then inject hydrophobic acrylic IOL into the capsular bag, as it is shown here, and position the haptic entirely in the bag. So this is the almost the end of the case. We will definitely need to remove the Malugin ring, which is now being done first with the help of the special manipulator. I do like to disengage in this case all scrolls from the contact with the iris. This is because that the anterior segment is quite small, so I will be having difficulties in manipulating with the ring otherwise. And then removal of the ring, and usually I do like to create a limited capsulotomy with vitrectomy probe, which is now done. And of course, sealing the incisions with the 10-0 nylon suture is a must in these pediatric cases. So in summary, we need to do appropriate midriatic protocol, maybe consider sometimes intracameral injection. Highly viscous OVD is helpful in maintaining the pupil size and dealing with capsulotomy. And of course, you need to consider using pupil expansion ring when the other strategies does not provide you a good size of the pupil. Thank you very much.
Thank you very much, Boris. Wonderful. I have a question before I ask Bruno to comment. What's the adult size and what's the pediatric size of your ring that you recommend?
There is no special pediatric size of the rings. The ring we are currently use is having 7 millimeter in diameter and 6.25. And in pediatric cases, I use the second generation of the ring, which is thinner and more elastic. And I use the smaller size available.
Okay, thank you. Bruno, any comments?
That's a great lecture. It's very challenging to implant the Malugin ring in very shallow eyes. As I'm also a corneal surgeon, I have received some referral of patients with testament membrane detachment after Malugin ring in some surgeons that were not experienced with this device, this wonderful device, who had managed to put this in very shallow and high hyperopic patients. So I would like to ask Dr. Malugin, what are the pearls of implanting the wonderful device in these very shallow anterior chambers?
Basically, in very shallow chambers, even manipulations with the regular instruments, such as chopper or lens manipulator or Phaco needle, may give you the detachment, the descent detachment. So that's obviously the case. However, if you are using highly cohesive OVD, such as Heal 5 or similar, so you have a chance to deepen the chamber, and in spite of some posterior pressure that you may also anticipate in the short eyes, the eyes with the shallow anterior chamber. So you need to deepen the anterior chamber very well. Also, the size of the incision is quite critical, because if you do it a little bit too tight by entering the eye, the anterior chamber with the injector, so you can actually damage the descent membrane. So I think you have to keep an eye on the chamber depth and use very cohesive, highly cohesive OVD. I think these are two major pearls.
Thank you. Thank you.
Okay, I think we have only 2 minutes left now. Thomas, any final comments?
Well, I just was thinking about nuclear chips because of the case from David and Rob, and I was thinking about how cool it is when you have a small little nuclear chip. You can use Malyugin's inserter to go in there and grab them and pull them out. So just keep that in mind. If you have a smaller nuclear piece, you can take the Malyugin ring inserter, you throw away the Malyugin ring, or give it to your friend for an earring or something. And then go in there with just the inserter, go in there and grab that nuclear chip, pull it into the cylinder of the inserter and take it out. It's kind of a cool technique. But all that aside, I just want to thank everyone for participating. It's been fun. I appreciate the people that had to get up early. And Dr. Agarwal, everyone feels like you're their brother, and we feel like we're part of a big family. And I certainly feel that way. And thanks for including us.
You're not the only one, Thomas. We all feel the same way. So thank you. And I really appreciate the expert comments by our panelists, Bonnie, Kendall, and Bruno. We had a great faculty of speakers, of course, but overall, I learned a lot, and I hope you all have. So thank you so much for participation. And we need to move on for the next session with the time we have. But thank you once again, everybody. Thank you.
Thank you very much, Abhay Vasavda and Tom Oting and the entire top team who have come for the Phaco Nightmare session. Boris, can you just stop sharing your screen? And Mahipal, we have now the most interesting session, which is going to start soon. And that is none other than the film festival. Mahipal, few words from you.
Yeah, so I think this is a great film festival. We had a great session. First 3 sessions were great. In the film festival, we had a record number of entries, and I think we have great judges who are there right with us. So Gaurav Luthra, Namrata Sharma, Dr. Bharti, Partha Biswas, Dr. Tityal, and Suhas Haldipurkar. They had to go through the grueling task of seeing all the video films and get out the best in the best. So we have them, and they will walk you through this film festival where there are categories for which awards have been given, are to be given both for the runners-up and for the winners. So without any delay, let's go on to the film festival. I think is there a small video before we start the film festival?
Yes, sir. We have a sponsor video. Yes.
Yeah, so just run the sponsor video and then I'll pass it over to the judges. Thank you very much. Thank you very much, Census, for sponsoring this particular session. And over to the judges who have really worked overtime to get the best out of this. So over to you, all of you, the judges, please.
Ashwin?
We should invite Ashwin to take over.
Ashwin?
Where is Ashwin?
Yeah, Ashwin is the man behind the whole thing today.
Ashwin has not joined, has he?
Mahipal, how many total videos?
We have more than 206 films.
We had 206 videos,
Wow.
and we had 6 judges judging them, and we all met a couple of times. And we have total of 13 awards. We have the grand prize, and we have 6 categories with the runners-up and the winners. And they were tremendous videos this time. And I think we really had a tough time to do it because there were so many contenders in all the categories. It was amazing.
So we have 6 categories for which the awards will be there. That is best in cataract and cataract complications. I think, okay, Ashwin is there.
Yeah, Ashwin is here. we are waiting for Dr. Ashwin to join. He's likely to join us any moment. I think lots of hard work behind the
Hello,
whole
everybody.
process.
You are muted.
Welcome to IFA. Every year, the IFA puts on a grand show for all its producers. It wishes to recognize those people who have done extremely well to making these films and awarding them for their efforts through the year. This year has been extremely special. We got a record 200 plus submissions this year, and all of these beautiful videos have been placed on your website, IIRSI.com, for your viewing. Members, no members, doesn't matter. The credibility of IFA. Well, since its inception, the credibility of IFA has completely relied on its judges and its judging process to award the right person the right award. And this year has been no easy task. Without any further ado, let me introduce you all to the judges. We have with us Dr. Suhas Haldipurkar, Dr. Sudhank Bharti, Dr. Partha Biswas, Jeevan Tityal, Namrata Sharma, and Gaurav Luthra, our Chief Judge. I'd love for Dr. Suhas Haldipurkar to say a few words about the judging process in IFA this year.
Thank you, Dr. Ashwin. Judging these lovely videos has been an educative and enlightening experience to all of us. We had a couple of Zoom meetings just to formulate the appropriate method to judge these videos so that, yeah?
Dr. Suhas?
Okay. Yes?
Yeah, you are audible. Carry on.
Go ahead, Suhas.
Go ahead.
Thank you, Dr. Ashwin. Judging these videos has been very educative and enlightening experience to all of us. We had a couple of Zoom meetings just to formulate the appropriate method to judge these videos to give proper justice to each and every one of them. In fact, each of us, the 6 of us, got 65 videos to judge, and finally the finalists from all of us that went on to become 45 videos were again screened by each of us, and it was quite a daunting task to select the winners and the runners-up. In fact, we are so happy that the kind of quality these videos we saw was exceptional, and we are so sure that from now onwards, IFA would be the most watched event every year. And my congratulations to Ashwin and Amar. Thank you.
Thank you very much, Dr. Suhas. But I think honestly, the thank you must go back to these 6 amazing people who have done exceptionally well, to be really honest. They put in sweat and a lot of time, to be really honest. Coming back, let's move on with the categories that are going to be awarded today. The categories are these, and I'll take you through each of them while we go through the program. But what are the awards? Well, we went global this year, and we also had social distancing in our minds. So we didn't really know how to actually give an award all the way in Brazil should somebody win. We didn't know how to do that. So what we've done is we're giving away Amazon gift cards this year as award categories. For runner-up, a 2,500 rupee Amazon gift card will go. For a winner, 5,000 rupees. And for the grand prize, there will be a 10,000 rupee grand prize Amazon gift card that will be sent to them. Without any further ado now, let's move on with the first category of awards, Best in Cataract and Cataract Complications. And to give away these awards, can I please have on stage Dr. Abhay Vasavda and Dr. Sudhank Bharti.
Thank you, Ashwin. I must appreciate your effort.
Can we have the runner-up of this video of this category being announced by Dr. Abhay Vasavda, please?
The runner-up on this category is Professor Gerd Auffat from Heidelberg, CSI Heidelberg, focus on multifocal and EDOF technology. I know Gerd personally, and he's brilliant. He has contributed so much, and he's great in newer technology. So he deserves this.
Congratulations, Dr. Gerd. Congratulations, Dr. Alfred. And
do I announce?
Can we have the video, please? Can we please play the video of the runner-up?
The images were captured with a digital camera setup. Video films as well as still pictures were assessed. Looking at the analysis, we used specific software for analyzing the light distribution to define the peaks of the near, intermediate, and distance, or the EDOF range of vision area.
Thank you very much. And also to present the winner in the same category, can we have Dr. Bharti please announce the winner in the best in cataract and cataract complications? Can we have the spotlight on Dr. Bharti, please? Oh, can you unmute yourself, Dr. Bharti?
Okay. Is that, am I audible now?
Yes.
Yeah.
Yes, sir.
So the best in cataract and cataract complication video winner is Dr. Samresh Srivastav, Thinking Out of the Bag.
Fantastic, Dr. Samresh. Thank you so much for sending in this video. And very soon, let's see the video, please.
Thinking out of the bag, tackling the narrow anterior segment,
the shallow anterior chamber, the convex iris configuration, a closed angle, and an anteriorly rotated ciliary body. The same patient now comes for his second eye surgery. Following posterior capsulorhexis, a 3-piece IOL is chosen over a single-piece IOL. The haptics positioned into the ciliary sulcus. And the optic is slid behind both the anterior and the posterior capsulorhexis margins. Can you see how the iris has fallen back? The anterior chamber has deepened. The angle is no longer crowded. And more importantly, look how the ciliary body, which was rotated anteriorly, has now fallen back to its normal orientation.
Before moving on, thank you so much, Dr. Abhay and Dr. Bharti. Before moving on, the judges really felt that some of the videos really needed some special mention. And we've created a special mention category. These videos are exceptionally good and really something that the judges felt that every person viewing the Film Festival Award show must watch. This first video in the special mention category, and everybody can watch this on the website, is Joyita Das, by Joyita Das, The Power of Z-Plasty. Please go and have a look at this video. It's exceptionally good. Moving on to the next category, we have the best in cornea and refractive surgery. And to give away this award, can we please have on stage Dr. Mahipal Sachdev and Namrata Sharma. Thank you. And can we have the runner-up of this category being announced by Dr. Namrata Sharma, please?
So the best in cornea and refractive surgery runner-up goes to my very good friend and a great innovator, Dr. Susan Jacob, for host prismatic scaffolding technique. I think a great technique and an excellent video. You all should, all the cornea surgeons should actually see this video. Thank you.
Fantastic. Congratulations, Dr. Susan. And can we have a look at Susan's video, please?
Host decimetric scaffold. And it is now time to do the host decimetric scaffolding. Using a reverse Sinski hook, The host decimate membrane is gently teased out from under the graft and allowed to overlap the graft from the posterior aspect in a scaffolding manner. This can be done without any graft touch by starting at the free edge of the host decimate's membrane and teasing it out by moving the reverse Sinskey hook along the margin of the graft. This allows scaffolding of the graft using the native host decimate's membrane.
Congratulations, Susan. And moving on to the winner of this category, the best in cornea and refractive surgery, can we have Dr. Mahipal please announce the winner?
Thank you very much, Ashwin. Pleasure announcing the winner. And the winner is none other than who has done proud to Indian ophthalmology. He's done proud to Indian ophthalmologist by also his administrative and surgical skills. And the best in the category of cornea and refractive surgery goes to our own Professor Dr. Jagatram from PGI, Director PGI, who made this beautiful film on mega phakic intraocular lens. Congratulations, Professor Jagatram, for a fantastic video.
Congratulations, Dr. Jagatram. And just to do the honors, can we see the video as well?
Myopia in ophthalmic eyes can be difficult to manage. A subset of these children with unilateral ophthalmos provide a unique set of challenges in their visual rehabilitation. So what next for this child? This was surely a management challenge. Or is there a way we can visually rehabilitate this child using this potential space between the iris and the crystalline lens? The last option appeared the most appealing and physiological in this case of unilateral ophthalmos with high myopia. We believe that customized mega phakic intraocular lenses are a viable option and may well be the way forward in the management of high myopia due to unilateral ophthalmos. Thank you.
Congratulations, Dr. Jagatram. Before moving to the third category, and thank you, presenters Mahipal and Dr. Namrata. Special mention number 2 would be Dr. Roop Prakyat's video of targeting negative dysphotopsia, the ND ring. Please have a look at this video. It's exceptionally good again. Moving on, the best in other specialty category. And to present this award, can we please have on stage Dr. Lalit Verma and Dr. Suhas Haldipurkar. Fantastic. Thank you so much. And moving to the runner-up in this category, can I please have Dr. Suhas Haldipurkar announce the winner of the runner-up in this category?
Thank you, Dr. Ashwin. The Dr. Veer Singh, who's made a film on PDR tame, no PVD, flat fibrovascular proliferation, managed the 10K way. And Dr. Veer Singh is the runner-up. Beautiful film, very nicely made.
Lovely. Thank you, Dr. Suhas, and congratulations, Dr. Veer. And let's have a look at his video.
This is a case of proliferative diabetic retinopathy with flat fibrovascular membrane, managed by a combined phaco vitrectomy surgery, using 25-gauge 10K beveled cutter from Alcon. The aim of this video presentation is to demonstrate the various tips and tricks to manage such cases of PDR without a PVD, and the advantages offered by the 25-gauge 10K beveled tip cutter in these challenging cases. The beveled tip design allows the cutting port to come very close to the retina, making it easier to access tissue planes. 10,000 cut rate increases safety and allows better control and efficiency during surgery.
Lovely. Special mention, video number 3. We have again Professor Gerd Offroth, CSI Heidelberg's DMEC with artificial implant instead of human tissue. It's an extremely innovative and different video. You must watch it. It's on your website anytime you want, on video on demand. Moving on to the next category. Thank you, Dr. Lalit. And
I have to announce.
We have Dr. Lalit. Can you please announce the winner in this category, please?
Yeah. Thank you, Ashwin, for doing a great job for IFA. It's nearly a live atmosphere what you have created. Congratulations to you and all the 6 judges. The winner in this other specialty category is Dr. Pritika Sen and her video entitled Journey to the Center of the Tumor. A big round of applause to Dr. Sen. Congratulations.
Congratulations, Dr. Mritika Sen. And let's have a look at her winning video in the other specialty category.
Immunohistochemistry employs antibodies to identify cellular components or antigens which are tissue specific. It is done on sections prepared from routinely processed paraffin embedded tissues. In ocular oncology, this is done for undifferentiated and poorly differentiated malignant neoplasia, differentiating lymphoproliferative lesions, histiocytic lesions, round cell tumors, spindle cell neoplasia, retinoblastoma, uveal melanoma, to distinguish between benign and malignant pigmented lesions, to differentiate between sebaceous, squamous, and basal cell carcinoma of the eyelid, and to identify markers that are amenable to targeted therapy.
Congratulations, all the winners, runner-up of all the 3 categories. Moving on to the next category, we have the best new technique, new device and innovation category. And thank you, presenters, for presenting that with me. Can we please call on stage Dr. Chitra Rammurthy and Dr. Partha Biswas for this category? Thank you so much. Moving to the runner-up, can I please call upon Dr. Partha Biswas to announce the runner-up in this category?
Thank you very much, Ashwin, and it's a pleasure to be here. And it's wonderful to be a part of the judging process. So much learning for every one of us. And the beauty was the transparency and the amount of patience and passion that every one of us showed. So, and this category is a very, very special category because it shows the beautiful, imaginative human mind, thinking out of the box, thinking on beyond the ordinary to the extraordinary. So I have the pleasure to announce the runner-up in the best new technique, new devices and innovations, Dr. Vivekanandan VR, My Way for COVID Cataract category. This is the new technique, new devices category. Thank you very much and many, many congratulations, Dr. Vivekanandan.
Congratulations, Dr. Vivekanandan. Can we also please share his video with everybody?
Corneal endothelial damage due to high Phaco parameters, zonular damage, posterior capsular rupture, nucleus or cortex drop, to prevent the nucleus and probe from hitting the PC. This search led us to realize that we can use IOL as a protective barrier. The first chop is always a challenge in a hard mobile nucleus. Then it dawned on us, why not use Milo?
Congratulations. Moving on to the winner in this category, can I please call on Dr. Chitra Rammurthy to announce the winner?
Winner is Dr. Prithvi Chandrakant for his video IOL score, and wishing you, Dr. Prithvi, for your brilliant innovation and a future where more and more innovative awards are won by you. All the very best.
Congratulations, Dr. Prithvi. And just to do the honors, can we also please have a look at the video?
The IOL scope. Here we describe an innovative device which can be easily made and acts as a microscope for point of care diagnostic using just a smartphone and IOLs, called the IOL scope. Required chart paper 4 into 2 centimeters, intraocular lens 30 diopters for 4 numbers, micropore, paper puncher and liquid adhesives. Now with the help of a micropore, we can attach the IOL scope onto the camera of a smartphone.
Wow, isn't that really innovative? Thank you, Dr. Chitra and Dr. Partha. Moving on, before we move to the next category, the last mention in the special mention category, I wanted to announce the name Dr. Deepthi Mehta, management of a corneal bee sting injury. It's an amazing video you must watch. Please go into the website to watch that video. And moving to the next category is the best teaching video category. We're coming into the big ring now. So we're calling upon Dr. G.S. Dhami and Dr. Jeevan Tityal to give away this award. The runner-up of this, can I please have Dr. Jeevan Tityal announce the winner in the runner-up category for the best teaching video?
Thank you, Ashwin. I appreciate most of the videos were wonderful in quality and in teaching wise. I say all of them were winners, but unfortunately we have to pick up one runners-up and one winner. It is my pleasure to announce the third generation of Om Prakash. That is Dr. Tusheya Om Prakash, the young, talented, bright, innovative mind, and he's done a wonderful work in this video, which is titled as Zonulopathy, Different Case Scenarios. I appreciate their effort. It's wonderful video. My heartiest congratulations to Om Prakash family and especially to Tusheya for winning this award.
Well, congratulations Tusheya for this beautiful video, and let's have a look at the video, please.
There are no financial disclosures in the subject matter of the film. How do we predict generalized zonulopathy? A thorough preoperative evaluation by asking the patient's history is essential. Clinically, slit lamp evaluation can reveal phacodonosis, pseudoexfoliation. Often, there is associated shallow anterior chamber depth and small pupil due to inadequate holding back of the crystalline lens because of zonulopathy. Any shallow anterior chamber depth with normal axial length should raise a strong suspicion to weak zonules. After evaluation, have intraoperative surprise.
Congratulations, Tusheya. Moving to the winner in this best teaching video category, can we have Dr. Dhami please announce the winner?
At the onset, Ashwin, congrats. It's hardly a virtual, but looks all real. A very great film festival. Well, the winner in the best teaching video, Prasanna Venkatesh Ramesh, for his video Neophytes, Gonioscopist, Animative and Videographic Atlas with focal points for effective practice. Congrats, Dr. Ramesh.
Congratulations, Prasanna Venkatesh Ramesh. Please, we're very happy that this is also probably the first time, but let's have a look at this video, please.
Beginner's guide on how to go about performing gonioscopy. Common clinical scenarios. In a PXF patient, gonioscopy may reveal a sample as the slide. In eye syndrome patients, prominent anteriorly displaced Schwalbe's line with PAS may be noted. In pigment dispersion syndrome, homogeneous pigmentation of trabecular meshwork is seen. In patients with history of trauma, angle recession with broad ciliary body band and a disinserted iris processes should be ruled out. Cases of aniridia in congenital glaucomas may reveal an anteriorly displaced rudimentary iris stump.
Congratulations, Dr. Ramesh. Moving to the best new producer category, and can we please thank you presenters for being with me on the stage. But can we please have on stage Dr. Lahane and Dr. Gaurav Luthra to give away the best new producer category. So this category has been specifically made for people who have first time submitted or not over the past 5 years. So let's have Dr. Gaurav Luthra please present the runner-up in this category. Can we have Dr. Gaurav, please?
Thanks, Ashwin. And, at the outset, it's been a great experience this time for this virtual film festival that we've done, and the judging process has been tremendous. It's been very tough as well, and Ashwin, you've done an amazing job. I must commend all your efforts for putting this across. And it's my privilege to announce this award for the runners-up for the best new producer, and this has been taken by someone who's just won another award, Dr. Prasanna Venkatesh Ramesh. And he has made an amazing video on the innovative utilization of patients' triage with integrated information system during COVID crisis. And I'm sure that a lot of people will learn a lot in this ongoing COVID crisis if they watch this video on how to run your OPDs better and how to run your processes better. Congratulations, Dr. Prasanna, for winning 2 awards in this festival.
Well, congratulations, but let's have a look at the video, please.
Innovative utilization of the patient's triage wait time with rapid and intuitive integrated information system during COVID crisis. This is a picture showing our pre-COVID waiting hall, which is now converted into an isolation cubicle meant only for OPD and investigations. This cubicle, made of acrylic, is transparent and consists of openings in front of every instrument for the patient to rest their chin and forehead while performing the test. The cubicle is devised with sliders to close the opening when the test is not performed.
Wow, congratulations, Dr. Prasanna. But moving on to the winner in this category, can I please have Dr. Lahane announce the winner of the new producer category?
Good evening, everybody. Ashwin, excellent show. I think it is the best show that you have organized. And the winner in the best new producer is Dr. Pawan Kumar, and his title is Going Live to the Surgical Technique with GoPro Video Recording. Congratulations, Dr. Pawan Kumar.
Congratulations, Pawan, and that's a very innovative way of thinking, but fantastic video. Let's have a look at this actual video.
Giving life to surgical training with GoPro Live during COVID crisis. We have mounted GoPro camera to the side scope of the surgical microscope, which is paired with the tablet through the GoPro app. This video recording system has turned out to be extremely useful during the COVID times. Learning from the experts. When an expert surgeon is operating, the surgery can be live streamed as in Facebook or YouTube, which can be watched by the junior surgeons through their smartphone or laptop easily at their own pace. Since GoPro comes with an inbuilt microphone, the operating surgeon can give live commentary of the steps being performed.
The Rexis should be performed under high molecular weight visco.
This will greatly benefit a larger group of students.
Thank you very much, Dr. Lahane and Dr. Gaurav, for being with me on this one. Coming out to the final and the last award for the night, and probably the last video that you're going to watch today, is the grand prize of this award show, the whole IIFA grand prize. And I would definitely love to have a gallery view, please, and all the 6 judges and the presenters give away the grand prize winner, and we'll watch the video immediately after that.
I think let's all announce together.
Okay.
The grand prize
goes to Dr. Sheetal Raj for
simplifying. Simplifying the simple.
It's the title of the video.
So Dr. Sheetal, congratulations.
Yeah.
4 flange technique.
Simplifying the simple feasibility of 4 flange technique with a new design of a foldable IOL. But let's have a look at the video because it's exceptionally good, and you must all go watch it on the IIRSI website.
In the original 4-flange technique, the 5O proline suture is fed in the lumen of a hypodermic needle within the anterior chamber and exteriorized through a sclerotomy 2 mm from the limbus on either sides. In our modification, the double needles are pre-prepared by feeding a 5 centimeter long strip of 6O proline suture into the lumen of a 27 gauge needle under direct or microscope visualization. The needle is then introduced into the sclera 1.75 millimeters from the limbus and the suture advanced within the shaft of the needle. Once the suture is visible in the anterior chamber, it is grasped with a microforceps and exteriorized. The same is repeated on the other side, 180 degrees apart. The suture ends are then passed through the eyelets of a non-foldable IOL and cauterized to create flanges, following which the IOL is positioned behind the pupil, outer sutures pulled anteriorly and cauterized to create 2 external flanges, which are then buried under the conjunctiva.
Well, congratulations, Dr. Sheetal. The judges, I know I put you in another sticky wicket by asking all of you to announce the name at the same time. But thank you for being with me for so many troublesome Zoom calls and meetings that we had. And thank you all the audiences to watch the IFA. And we hope to be back again. For sure, the videos are going to be on our website for a long time. We've had a record attendance today. I don't know the numbers yet, but it's been a record attendance for sure. And we wanted to say thank you for watching the IIRSI online annual event that has gone global today. We wanted to also tell you that tomorrow we're going to have the show repeat at 5:30 with different sessions in each hall, ABC. So please come back to the same website, same registration, everything remains the same. The talks will be very different and very, very entertaining. Thank you so much.
Very
Sayonara
nice.
and have
Very nice. Ashwin, congrats.
Congratulations, Ashwin.
Congrats, Ashwin.
Amar, great show.
Wonderful work.
Very well organized.
Very wonderful.
Dr. Aman and Ashwin both for a tremendous job. And tomorrow we have the award ceremony again at 6 p.m. in Hall A for the Ophthalmic Photography Awards. And again, 550 entries and 10 categories. So please be there for that as well. And I'd like to thank all the judges as well for and all the senior members who came away with the prizes. Thank you so much.
Thank you.
Bye-bye.
Thank you.
Thank you. Bye-bye.